Recording in progress. Recording stopped.
Hello everybody,
Recording in progress.
I am Sanika, your host for this prestigious virtual meeting. Thank you for joining us on ICA Academics Annual Day 2021. For the last 1 year, every Wednesday at 7 p.m. Indian time, ICA webinar was on air without any exceptions. The ICA plans to continue this academic initiative in the coming Wednesdays also and take this program to newer heights. Let's begin today's program with welcome address by our Chief Trustee, Dr. V.P. Kumra.
Esteemed members of the Indian College of Anaesthesiologists, national and international faculty members of the ISA National and the invited faculty. It is my proud privilege and pleasure to welcome you all today on the successful completion of our 1 year's webinar academic meeting since it started on this very day last year. It has been a year of hectic activities in spite of the ongoing COVID-19 pandemic. During the year, various important topics, especially related to the COVID pandemic, like critical care management, ventilator modes, oxygen therapy, and guidelines for the management of the COVID-19 infection and its complications were highlighted. In addition, important anesthesia topics, especially for the postgraduate students and practicing anesthesiologists, were also included. It would not have been possible without the active participation of our most knowledgeable CEOs, Professor Jayashree Sood and Professor Baljeet Singh, as well as the untiring efforts of Professor Sanish, our Chief Coordinator for the academic program, by drafting and communicating the weekly schedules well in time every Wednesday, before Wednesday. This all under the dynamic leadership of our President of the Indian College of Anaesthesiologists, Professor D. Radhakrishnan. He had the far-sightedness of involving even eminent international speakers like Kumar Vilani, and then further creating a perfect academic institution by appointing Professor Muralidhar Kanchi of Narayan Vidyalaya, Bangalore, as the Dean for the Indian College of Anaesthesiologists. The combined efforts delivered evident fruitful feast of academic program throughout the year every Wednesday as webinar academic schedule. On the occasion of the first anniversary of completing the academic activities of the Indian College of Anaesthesiologists, I, along with the executive body of the College of Anaesthesiology, under the able guidance of our patron and advisor, Professor Manorama Mittal, congratulate the whole team for the grand success on systemic execution of the academic program befitting the standards of the College of Anaesthesiology. Wishing you all once again the very best for the ongoing educational schedule. Thanking you. Long live Indian College of Anaesthesiologists. Jai Hind.
Thank you, Dr. Kumra. Your guidance and blessings are always inspirational to the college. Now, let's invite Chief Executive Officer of ICA, Dr. Jayashree Sood, for a brief introduction of ICA.
Good evening and welcome to the ICA Academics Annual Day. The Indian College of Anaesthesiologists was established in 2008 as a non-governmental, non-profitable academic institution. It is a professional organization with qualified anesthesiologists of India or of Indian origin. It represents a model of unity in structure and process. The vision of an Indian college was proposed by the then president of the Indian Society of Anesthesiologists in 1998, Dr. Manorama Mittal, who is now the patron of this college. With the timely intervention of Dr. V.P. Kumra, Dr. Radhakrishnan, late Dr. Shastri, and with the support of the ISA Delhi, this vision came into being. And the college was registered on the 21st November of 2008 as an autonomous body. This day is celebrated as the Founders' Day. The headquarters of the ICA are at Delhi with 5 regional zones. The aims of the college are to bring about uniformity in anesthesia education in India, to streamline the academic and practice activity in the specialty, and to have international accreditation of our qualifications. The first annual conference was held in November 2009, 1 year after the inception of the college, and subsequently it is being held every year. The first international conference was held in September 2019. Several courses and fellowships are being conducted under the aegis of the ICA. The college is awarding honorary fellowships to its eligible ICA members. It awards what is known as the FICA, the Fellowship of the Indian College of Anesthesiologists, to the ICA members who have creditable academic achievements. 5 honorary fellowships are awarded every year at the convocation, which is held at the National annual conference. The ICA has also collaborated with the Royal College of Anaesthetists to conduct the primary FRCA examination in Delhi. This process is under review. The ICA also signed an MOU in 2019 with the Samba leadership with the idea of having bilateral relations of educational activities. It has also held meetings with the ASA leadership in 2019, and now we have started an academic affiliation with the ASA. The members of the ICA are gradually increasing, but we have a long way to go. Long live ICA. Welcome to all of you. Thank you very much.
Jayashree ma'am, thank you. Now it's over to our patron, Dr. Manorama Mittal, for felicitation.
I feel honored to be felicitated by the Working Committee of ICA. Please accept my sincere thanks. I want to share some of my thoughts with you all, especially the younger generation of anesthesiologists. It was during my tenure as the president of ISA in 1998, the concept of having an institute to cater to the various anesthesia needs of a vast country. This gave birth to Indian College of Anesthesiologists. The need of uniform standard of teaching and training of anesthesiologists was the need of the day. So postgraduate assembly was started in different parts of the country. And in difficult times of COVID era, the webinars have replaced the PG assemblies and have a vast reach. We provide anesthesia services to millions of patients every year. If we collect the data, we can mold our techniques and provide safe anesthesia. Our experience can benefit many other countries having similar problems. Another area requiring the attention of the college is audit. College should also set protocols, guidelines for district hospitals, nursing homes, medical colleges, teaching hospitals, and referral centers. My physical health is not as good as it should be, but my mental health is pretty good. Ideas keep coming in my mind, and I will share them with the working committee of ICA from time to time for their perusal. I wish the best for the future of the college. Thank you all.
Thank you, Dr. Mittal. The ICA is surely committed to taking the dream forward. The global leaders in anesthesiology have a definite role in the current status of anesthesia and its future. ICA Academics Annual Day 2021 is proud to present special featured presentations and a panel discussion on this topic. Our International Dean, Dr. Kumar G. Bellani, from University of Minnesota, will be moderating the session. Over to you, sir.
Greetings to everybody, and thank you, patrons and trustees of the Indian College of Anesthesiologists, thank you for this world meeting celebrating the academic annual day for the Indian College of Anesthesiologists. We are fortunate to have several world leaders to bless this occasion, and I begin with the first speaker, Wayne Morris, who is the president of the World Federation for the Society of Anesthesiology. Dr. Morris is a practicing anesthesiologist in New Zealand and trained in New Zealand and Australia and worked in Fiji for 2 years before studying in Christchurch. Dr. Morris is the current president, like I said, of the World Federation of Societies of Anesthesiologists and a member of the WFSA board and council. He served as chair of the Education Committee from 2012 to 2016 and director of programs from 2016 to 2020. We welcome Dr. Morris to give us his kind address to the Indian College of Anesthesiologists.
Hello to my many friends in India. Thank you very much for inviting me to speak at this important ICA webinar. I'm just going to share my screen. I've entitled this talk, The WFSA and the COVID-19 Pandemic. Greetings from New Zealand and Fiji. I'm currently in the capital of Fiji, Suva, helping local doctors and nurses with their response to an escalation of COVID-19 in the country. I usually work in Christchurch on the east coast of the South Island of New Zealand. And if you look at the globe, you can see that Fiji is in the middle part on the right and New Zealand is further south, also on the right part of the globe. I couldn't resist showing at least one photo from the World Test Championship final. I'd like to thank both teams for their sportsmanship. I think this was one of the standout features of the match. I've had a long association with Fiji. I worked here for 2 years in the early 2000s, and this photo was taken at the Fiji School of Medicine graduation in 2001. On the left side of the picture is Dr. Luke Nasendra, and he is a Fijian who has continued to work in Fiji since 2001. Beside me on the other side is Dr. Isal McCall, who is from Palau. This is a photo taken 2 days ago in the command centre for the COVID-19 response in Fiji. And Dr. Luke and I are discussing some aspects of the COVID response. Dr. Luke has put on some more weight and I've lost a lot of hair, but it is great to see him in this leadership position. And I think this has been the case in many parts of the world. Anesthesiologists have played a leading role in the fight against COVID-19. I like to think of anesthesiologists as the Swiss Army knives of medical specialists. We are multi-skilled, we are reliable, and we are often called on when times are tough. This is the front page of Time magazine from April last year, and it shows an anesthesiologist from northern Italy, Francesco Mencese. There are two things I'd like to point out about this front page. Firstly, the title of the special report, Heroes of the Front Lines. Anesthesiologists have been recognised around the world as frontline workers critical in the COVID-19 response. The other thing I'd like to point out is the quote from Dr. Francesco. We must get it into our heads that our lives have changed. And I think this is true for all of us. The pandemic has changed our lives in many ways, and it will impact our lives for some time to come. So I've only got a short time, but I'd just like to make a few points about how the COVID-19 pandemic has impacted the WFSA and also give a few examples of how the WFSA is responding. I know that many of you are familiar with the World Federation of Societies of Anesthesiologists. We represent anesthesiologists in 150 countries worldwide, and our vision is universal access to safe anesthesia. So what are some examples of the impact of the COVID-19 pandemic on the WFSA? Very importantly, many of our projects are on hold, and this includes the fellowship programs and face-to-face courses like SAFE and EPM. I know that many of you are involved with the fellowship program in centres in India, and it has been very frustrating that many of these, or all of these programs, have been on hold since the start of the pandemic. We've also had to postpone the World Congress of Anaesthesiologists, which was planned to be a face-to-face meeting in Prague last year. It is now a virtual meeting on the 1st to the 5th of September of this year. And like many of you, we've had to participate in countless Zoom meetings and we've had to use electronic media for a whole range of new functions. This is a screenshot of a board meeting, and it shows my colleagues on the WFSA board. Walid Habre from Switzerland at the top left. Then there's Carolina Haylock-Law, who is the Director of Programs from Honduras. Adrian Gelb, the current president. I will take over from Adrian in July next year. Davy Cheng from Canada. Davy is the treasurer, and he has recently shifted to China. Julian Gore-Booth, the CEO of the World Federation. Daniela Filipescu from Romania, the secretary. I'm at the bottom left, just after a night on call. That's why I am looking tired. Then we've got Basola Onajinabembe from Nigeria and Christina Lundgren from South Africa. So I'd now like to just give a few examples of how the WFSA has responded to the pandemic. And these are our advocacy work, our COVID-19 resources, and also changes to our education programs so that they can be delivered online. So advocacy has been incredibly important during this time, and we've made statements at the World Health Assembly and other meetings. We've really stressed two key themes: that there needs to be increased resourcing for anaesthesia and critical care, and we need to protect the workforce through provision of adequate PPE and ensuring that frontline workers get vaccinations. As all of you know, the non-COVID work that we're involved with continues even when there is a pandemic, and governments and other key stakeholders need to be aware that there is still an incredible need for treatment for non-COVID patients, and we need the resources to do this. Just looking at surgical need in particular, the Lancet Commission in 2015 found that 5 billion people do not have access to safe, affordable anaesthesia and surgical care when needed. It is likely that this number has gone up during the pandemic. The WFSA has developed a COVID-19 resource hub, and I'd encourage you to look at the WFSA website, www.wfsahq.org. This has more than 100 practical resources, and these have been carefully selected by an international group of experts. I think one thing that's really important about this resource hub is that there are specific resources for doctors and nurses working in low resource settings. So examples of some of the resources are a range of guidelines and other information about keeping you and your patients safe, information about perioperative care, and also information about critical and intensive care. As I said before, a lot of our education programs, which would normally be delivered face-to-face, are on hold. So during the last year, we've worked very hard to redevelop some of this material as online educational material. And what's been important with this is that we've been very keen to develop material that is highly interactive, that involves some real-time components through Zoom and other media, and can be delivered in a modular fashion. So I think this material that's been developed as a result of the COVID-19 pandemic is going to be very important going forward, just to improve the reach of some of these educational programs. As mentioned before, the World Congress is now a virtual meeting, and that is being held on the 1st to the 5th of September. We're really we're quite excited about this event now that the decision has been made for it to be a virtual meeting, and we think that it promises to be a truly unprecedented global meeting of our specialty. There are some advantages of having a virtual meeting because we think that it will increase the likelihood that many people from around the world will be able to attend because of the lower cost of attending a meeting like this rather than having to spend a lot of money to go to a face-to-face meeting. So the World Congress is now less than 2 months away. So in summary, anesthesiologists are like Swiss Army knives. We're multi-skilled, we're reliable, and we're called on when times are difficult. So WFSA will continue to advocate for greater resourcing and for resourcing to also protect our workforce. Online education is being developed, and this is part of the new normal. It's obviously important during the pandemic, but it's also going to be a fantastic way of delivering some of our educational projects in the future. So please look at the WFSA website, wfsahq.org. Please join us at the World Congress of Anaesthesiologists in September, less than 2 months away. Thank you again for inviting me to be at this meeting. I trust that you enjoy the meeting, the rest of the meeting, and I'm sorry that I can't be there in real time. Thank you again. Good evening.
Thank you, Dr. Morris, President-elect of WFSA. Our greetings also to Dr. Adrian Gelb, who is the present President of WFSA. For those who are on the meeting, if you have any questions, please put them on the chat, and we will try to answer them during the question and answer session. Our next speaker is the President of the American Society of Anesthesiologists, Dr. Beverly Phillip, who is the founding director of the Day Surgery Unit at Brigham and Women's Hospital and professor of anesthesia at Harvard Medical School in Boston. And like I said, she's the current president of the ASA. She has a long CV and has done a lot for anesthesiology, and she is going to give us the next message for this the ICA Academic Day. Dr. Beverly Phillip.
Thank you. Here to the Indian College of Anesthesiologists for the opportunity to represent ASA and to talk with you. I have no disclosures. Where I do like to begin my talk is with ASA's values. And these are patient safety, physician-led care, and scientific discovery. And we express these in our set of strategic pillars. But in particular, for me specifically, these have been a real focus of mine. So patient safety is always number one. But here we have research into scientific discovery and leadership and professional development, along with our inter-society collaborations, which is why we are here together. So let me focus on those two issues in particular. For education and leadership resources, ASA has a terrific education portfolio that in fact has been created and vetted by our members, leading practicing physician anesthesiologists, and they help you master the skills for daily practice. We do have, for our US-based complementary resident member offerings, and a robust joint provider program. So what specifically is in our education portfolio? Over 300 terrific offerings. There is, first of all, Anesthesia SimStat, which is the powerful, realistic online simulation training. We have two online education options that are very popular with our members. One that reinforces fundamental knowledge, and C, that provides key insights from the developing science. We have several other online courses, but as we are now coming out of the shadow of COVID, I want to highlight that we have two major excellent annual meeting live programs. One is our annual meeting in October, and the other is the Practice Management Conference. Now, one of our newest contributions to our education portfolio is the Point of Care Ultrasound or POCUS certificate program. And this has been created by ASA members for our profession to help you learn and demonstrate your knowledge in this new and evolving area. And it consists of 5 parts: that quality improvement, that evidence of training, and then you learn about image interpretation, image acquisition, and then there is a final exam after which you get a certificate of completion. And it's been wildly popular with our members. And if you want to find out more, please reach out to this email address, educationcenter@our asahq.org. Now, the highlight certainly of our education and science program is our annual meeting. And it will be live and in San Diego to identify we as anesthesiologists, our unique position as natural leaders as we move beyond COVID. Now, I know that not everybody will be able to come to San Diego, and that has to do with whether you are in the US or internationally. So ASA has created a virtual track that has a substantial selection of curated offerings. And these include accessing session recordings, medically challenging case posters, abstracts, several self-learning modules, and in fact, access to discussions, roundtable discussions, and access to virtual video chats in the social lounge. So please come online, take a look at this. I think you find this an amazing education opportunity for everyone. ASA also has a full portfolio of leadership resources so that we anesthesiologists can be the best institution, healthcare system, and leaders all together. There are several major categories of the leadership resources we offer. There are online programs, but I'd like to also highlight that at our relationship with the American College of Healthcare Executives, and there will be a masterclass at our live meeting, and also leadership sessions at Practice Management meeting, including credit to develop the criteria to get your designation for the American College of Healthcare Executives. The other major program that we run is an executive physician leadership program that we do together with Northwestern University's Kellogg School of Management. Again, this has been going for many years. It's a 4-day, 2 separate weekends, intensive program for physician leaders. This year, it will be on September 9th to 12th, and this is an amazing opportunity that's gotten nothing but rave reviews from earlier participants. The other topic that I'd like to address with you today is about our specialty promoting science. One aspect of this you may not be aware of, which is that ASA has helped develop an anesthesia research council. It was convened initially by the 3 organizations, ASA and then the International IARS, along with FAIR. And it consists of a group of individual research leaders, early scientific investigators, that's the ESAS group, and also our 3 organizational members. And there's a really good publication that came out in October 2020, looking at assessing the key challenges and opportunities for research, developing and promoting research in our specialty. And I think here I'd like to highlight some of their takeaways on how to support progress in anesthesia research. And there are 3 major themes. One is communication, communicating the value of anesthesia research to influence institutions, policymakers, government agencies, and other funders. Second, to investigate why it works well, where it works well. What are the characteristics of successful research departments? And how can we foster collaboration and conduct boot camps, how-tos for institutional leaders? And the third major point is engaging stakeholders to identify common themes where research is needed and what topics to focus on. This group met again this year. It related to the IRS meeting and is meeting and acting ongoing. ASA has other collaborations with the research community across the spectrum of what we do. Certainly, ASA has a committee on research, which functions as the grant study section for the FAIR grants. We do partner with our early career scientists organization, really promoting and enabling the work that they do, trying to be both physician anesthesiologists and expert research scientists. We've been collaborating with AUA on COVID-related research, and we have 2 sets of awards that we set up to recognize members on these branches of scientific work. The first is in education, where there is a Pinnacle Award, an Excellence in Research Award that is awarded once a year, and it is given out at the Rovenstein Lecture at the annual meeting, and also a joint program with Society for Education and Anesthesia about the Distinguished Educator Award. This is a mid-career award. Actually, both of these latter two were my idea, and I started. But this latter one, the Mid-Career Award, you can apply online. And this is really substantial credentials that you can show the education work that you are doing and add this onto your CV. On the research side, there is a similar Pinnacle Excellence in Research Award and the Presidential Scholar Award that is for early career investigators. I think any mention of supporting science has to highlight ASA's work with FAIR, the Foundation for Anesthesia Education and Research. ASA created FAIR in 1986 specifically to support and develop physician scientists. And we have continuously supported that organization since 1986. We do actively promote the work of FAIR in its publications and on our website, social media. You've no doubt noticed in some of my MMO, Monday Morning Outreach publications, I've also tried to highlight the work of this group. And by the end of this year, FAIR will have funded over $50 million in research grants and programs, making pivotal help providing to promote the careers of our anesthesiology research scientists. Now, one last point is that you cannot also talk about science in ASA without a real shout out to our journal Anesthesiology. It is the official peer-reviewed journal of our organization and also the premier peer-reviewed journal in our specialty. And it really does fulfill the mission of promoting scientific discovery in perioperative critical care and pain medicine. I think and many of you may have noticed under leadership of our current editor-in-chief that the focus has been, still while maintaining the really high quality of publications, to really highlight clinical applications for these, with the majority of the articles being new science in these clinical care areas. It's also the number one most used ASA member benefit, with over 73% usage rate, and we all use it and read it. Some of us just like to keep up to date by reading the summaries and the abstracts, and some of us pour through all the details, but it's an amazing way to keep right up with what is hot and new today. So with that, I thank you. It's been a real pleasure to talk with you. I hope that next time we can do this all together. Thank you very much.
Thank you, Beverly. That was great. Thank you also for being one of my mentors in the Society for Ambulatory Anesthesiology. The Indian College of Anesthesiology will benefit a lot from the collaboration with the ASA. And especially since they will be launching the journal for the Indian College of Anesthesiologists, we certainly can learn a lot from the ASA. I now welcome one of my other mentors from Society for Ambulatory Anesthesia, Dr. Bobby Jean Schweitzer, who is dual trained and boarded in anesthesiology and also internal medicine. And she's the author and editor of Preoperative Assessment and Management, which is currently in the 3rd edition. Dr. Schweitzer is a fellow of and president of the Society of Ambulatory Anesthesia. She's a fellow of the American College of Physicians and an elected member of the Association of University Anesthesiologists. She's the executive editor of ANA, Anesthesia Analgesia Practice, and on the editorial board of Anesthesiology and Anesthesia Analgesia. She also hosts a monthly podcast for anesthesiology. Welcome, Dr. Schweitzer.
Hello, I'm Bobby Jean Schweitzer, Systems Director for Perioperative Medicine at Inova Health in Fairfax, Virginia, United States, and I'm the current president of the Society for Ambulatory Anesthesia. I'm delighted to be joining you today for your meeting. Over the last year, I know we've all suffered tremendously, and my condolences go out to you and your family and friends for all of your losses. But SAMBA stepped up early during this terrible year and this pandemic to offer resources to our members and to ambulatory anesthesiologists around the world. We developed a variety of resources and guidelines, published updates regularly, and hosted many webinars. For example, we developed a COVID-safe checklist for ambulatory surgery centers to use. We published a guideline on timing of elective ambulatory surgery during COVID-19, how to appropriately test patients, and to how to keep a safe work environment. We have hosted numerous educational webinars over the years. We typically host 1 to 2 of those per month. Over the last year, many of these were devoted to COVID-19. However, more recently, we have transitioned back to our regular sort of offerings on a variety of ambulatory surgery topics. For example, on July 29th, we have this webinar coming up on outpatient perioperative management of the child with diabetes mellitus. Please check out our webinars on our website. The registration is complimentary. We also not only develop guidelines for the clinical care of patients, but we also have resources for medical directors and for those practicing management in ambulatory surgery centers. We have hosted an annual meeting for that. And we've also published this manual. Naraja Rajan was the editor of this, and SAMBA members do get a 25% discount. We've developed many guidelines. This was one of the first ones we developed. Dr. Garish Joshi has been the author and spearheaded many of these. This was a consensus statement on the selection of patients with obstructive sleep apnea undergoing ambulatory surgery. As you can see, we developed a very user-friendly guideline algorithm where one could follow patients along who either had diagnosed obstructive sleep apnea or those who were simply at risk for it. And we gave guidance around the patients who were safe to undergo procedures in an ambulatory surgery center. This is a guideline that we developed in association with the Society for Anesthesia and Sleep Medicine. In fact, SAMBA has collaborated with many different associations over the years to develop collaborative guidelines. This was one of the very first guidelines developed about 10 years ago. Again, Dr. Joshi was the first author on this. And this was a statement on the perioperative management of blood glucose in diabetic patients undergoing ambulatory surgery. We center many of our guidelines around simple questions that providers would ask when caring for patients. For example, we sought to determine whether there was a specific cutoff of a fasting blood sugar or hemoglobin A1C that would preclude a patient from safely undergoing surgery. And SAMBA determined, based on a review of the literature and the best evidence at the time, that there was not a specific glucose level or specific A1C. But we did recommend that surgery be postponed in patients with significant complications of hyperglycemia, such as severe dehydration, ketoacidosis, or hyperosmolar non-ketotic states. These are a couple more of the recent guidelines. In fact, our very first guideline in regional anesthesia was just published. Alberto Ardon was the lead author on that. And it was the use of pectoralis blocks in breast surgery. We collaborated with ACER, and Tong J. Gan was the first author of the fourth consensus guidelines for the management of postoperative nausea and vomiting. Dr. Gan is a member of SAMBA and a former president of this organization. I want to briefly touch on one specific topic that I think is very well suited for ambulatory surgery. And it's a condition that is very pertinent around the world, and especially in India. Cataracts account for a large number of reversible blind episodes, blind individuals throughout the developed and developing worlds. And the only really safe, effective treatment for cataracts is surgery. In India, there's up to 12 million individuals who are bilaterally blind from cataracts. Cataracts can be both congenital as well as develop with age. Out of every 10,000 births in India, about 15 of those children will be born with congenital cataracts. And there are currently about 3 million visually impaired children in India. And childhood cataracts account for about 14% of all of those cases of blindness. At age 30, about 0.5% of the population will have a cataracts. As you can see, as one ages, it becomes much more prevalent. In India, about 3 out of 4 individuals over the age of 60 will have cataracts. And 95% of those over the age of 70 will have cataracts. Cataracts are responsible for about up to 80% of all cases of blindness in India. The prevalence, the actual incidence of cataracts have actually decreased over the last decade. Much of that was due to Vision 2020, which is a World Health Organization initiative to decrease the incidence of blindness worldwide. However, because of the aging population in India, the actual number of people with cataracts has actually increased from about 7.75 20 years ago to currently 8.25 million individuals in India above the age of 50 living with cataract. So, as I mentioned, surgery is really the only effective treatment for cataracts. But you can see here on this map showing that much of India, it actually has a very low rate of cataract surgery. There's only a couple of areas that are considered at high rates, and these are the rates that are necessary to actually decrease the incidence of blindness. So there's quite a need for more offerings of surgery for patients who do have cataract disease. So I do want to really emphasize that cataract surgery is extremely low risk. In fact, it's the lowest risk surgery that is offered. And yet it is one of the most common surgeries that are offered. And many of the patients undergoing cataract surgery are elderly and do have comorbid disease. But the mortality is exceedingly low, less than 0.1%. And major morbidity is also very, very low, on average about 0.04%. In a Cochrane review published a few years ago, over almost 22,000 patients, they only had adverse events occurring in about 3.3% of patients. And only 0.28% of those individuals having cataract surgery required hospitalization. And there are only 3 deaths for a very, very low rate of death. In fact, it's been estimated that one is more likely to get killed in a motor vehicle accident going back and forth to the ambulatory surgery center or the hospital than suffer death during cataract surgery. And in fact, the risk of dying on the day you have cataract surgery, the day after cataract surgery, is actually lower than actuarial data based on insurance data for individuals at any given age. So I sometimes sort of tongue-in-cheek say, if you think you're going to die or you're feeling particularly ill, go out and have cataract surgery. It's not actually that cataract surgery is protective necessarily, but just the mere fact that individuals are able to get to the facility to have their cataract surgery shows that they've selected themselves out as being safe to undergo the cataract surgery. This is likely due to the fact that there is absolutely no stress response associated with cataract surgery because there is no major organ disruption, no fluid shifts, no blood loss, and very, very minimal postoperative pain. Additionally, almost all cataract surgery can be performed with topical anesthesia or perioperative blocks, thus avoiding general anesthesia. So there's actually a paucity of evidence to suggest that general anesthesia raises the risk with cataract surgery, even if that is required. A well-conducted general anesthetic is very, very safe for patients undergoing cataract surgery. And absolutely everyone agrees that there's absolutely no need for preoperative testing. There's no need for ECGs, no need for blood tests. In fact, having cataract surgery is probably less stressful for patients than going to the dentist. Additionally, it's important to remember that one should not even be measuring blood glucose levels or potassium levels, or even measuring blood pressures on the morning of surgery prior to cataract surgery, because there's no evidence at all that those immediate preoperative values predict any risk. In fact, many guidelines say that unless you're concerned about a low glucose level or a low blood pressure level, you should just proceed with cataract surgery without any concerns. So I think there's only one important question that should be asked. Can the patient get to the facility and lie flat for approximately 30 to 45 minutes? If so, there's almost no exclusions to undergo safe cataract surgery. But I do want to alert everyone that there's a publication coming out. It's the absolutely latest SAMA guideline. It's due to be published actually right before this meeting in June of 2021, and it's the preoperative care for cataract surgery guideline. Many of the authors are SAMBA members, and there was a very collaborative effort to address the need of patients undergoing cataract surgery. We used a typical question approach as well for this, asking questions such as, does hypertension warrant cancellation of cataract surgery? Or can an ASA physical status 4 patient safely undergo cataract surgery in a freestanding ambulatory surgery center? And does hyperglycemia warrant cancellation of cataract surgery? So I urge you to look out for this publication. It will be published in Anesthesia and Analgesia, and I believe it will help you safely provide care for many, many patients anticipating cataract surgery, which is such an important initiative to try to lower the risk of blindness and improve the quality of life and the health status of individuals who suffer blindness. Thank you very, very much for inviting me to participate in your meeting. I wish you the best, and I wish you continued success in fighting COVID-19. Thank you.
Thank you, Bobby. That was great. It's nice to have the ICA collaborate with the Society for Ambulatory Anesthesiology, and hopefully that together we can come up with some more guidelines in the future, taking into consideration the needs of anesthesia in India and surrounding countries. It is my honor now to introduce the next speaker, Professor Ravi Mahajan, who is the president of the Royal College of Anaesthetists. Professor Ravi Mahajan qualified in anesthesia in 1985 in India and came to the United Kingdom in 1988 and has since had 30 years of experience in the national health system in the UK. During this time, Ravi has been supporting the development of a culture that instinctively puts patient safety first in all considerations, something that we've been hearing all along by our leaders in anesthesia. And this was a significant change seen in his time as a clinician. Serving as a council member since 2007, in 2016 became vice president and president since September 2018, alongside the role as a professor of anesthesia and intensive care at the University Hospitals in Nottingham. It's a pleasure to welcome Ravi, and we look forward to your presentation.
Thank you, Dr. Bellany, for your introduction. And thank you to ICA for inviting me to speak on the future direction for anesthesia as a specialty. And I must set the context here that my brief talk for the next few minutes is going to be mainly related to the context as it is happening in the UK, but it is also applicable to most of the Western world and some parts of India. So I'll go through the current climate and then the opportunities and where we are heading in terms of future of our specialty. So let me set the landscape first. The landscape is very clear. The patients are getting older. The comorbidities are on the rise. The staffing levels, if at all, are static and not are increasing with the demand, and there is not much money in the system. In fact, there are data to suggest that as the comorbidities increase, you spend more money, and of course, you would know that you have to spend more resources to look after more sick patients. Data from the UK would suggest, and I'm sure it's the same in other parts of the world as well, it would suggest that about 25% of our patients are seriously comorbid. So they do carry two or more comorbidities. And 75% of our resources are utilized on these 25% patients. So the focus for the specialty going into the future is going to be mainly on how do we care for the patients with comorbidity so that the costs are reduced. Not only that, so that the system is made much more efficient, and most importantly, so that our patients benefit. This slide will show that as we increase in our age, we suffer with one or more or even up to 8 system disorders. But most of 65% of people who are at the age of 65 would have 2 or more comorbidities. So 2/3 of patients over 65 would have 2 or more comorbidities. And that's quite significant to appreciate. And COVID pandemic, of course, has suggested or has implied that public health science, population health concepts are going to be very, very important going forward. Public will need to take some responsibility for their own health. And in terms of healthcare delivery, it has to be integrated, flexible, agile, and timely. And of course, a digital agenda and communications and improved communications throughout will help in integrating the services. So that is what COVID pandemic is continuing to teach us as we're going into the future. So in the future, the opportunity actually is to provide better quality service with lesser amount of money. And of course, science and technological developments are there. But where I'm focusing today is the delivery, the manner how in which we deliver the care going into the future. And that's where the organizations like WFSA, the organizations like Royal College of Anaesthetists have opportunities to increase the spheres of influence and show leadership in how in the future, we are going to shape our specialty and the way we deliver care to our patients. In terms of preventing, smoking, alcohol, obesity, we know all these are preventable, this is where some behaviors can be changed. And we know that preoperative period is quite a good period to catch patients and have system in support where these behaviors can be changed. And there are data coming from the UK to suggest that patients who are counseled during preoperative period actually end up leaving smoking or change behaviors with regards to managing obesity or alcoholism going into future, but also in the long time into their postoperative period. Big ticket items also include cancer, the diabetes, dementia, frailty, as we know. But what we also know that there are many papers and data that are upcoming which suggest that if you prehabilitate patients, make them exercise, if you prognosticate accurately, have a shared decision-making, multidisciplinary decision-making into place, optimize patients' condition, and look after their enhanced recovery period and go it through the enhanced recovery program, you could then improve their composite outcomes. And we've shown that this kind of integrated approach from preoperative period to intraoperative and going into postoperative period or throughout the perioperative journey of the patient actually improves their outcomes, reduces the length of stay, reduces the mortality, and very importantly, reduces the number of complications that patients end up suffering, and particularly relevant to patients with comorbidities. And we have shown with our perioperative quality improvement national program that certain simple measures like preventing or treating diabetes and anemia preoperatively, individualized risk assessment, putting patients through enhanced recovery program, individualized pain management, early mobilizing, all these things really help patients getting better sooner. Patients like it. They like comprehensive preparation, which includes optimization, weight reduction, improving fitness, psychological support, stopping smoking and alcohol before they undergo surgery. And the recovery is much faster, much quicker. And it is important, as this slide will show, what you have on your left is different kinds of surgeries. So whether they're abdominal or urological or upper GI or thoracics, the numbers in blue circles are the number of days that a patient spends on an average in postoperative period. And numbers in red circles are the numbers that patient would spend in postoperative period if they get one organ complication. So you can see that the length of stay increases 3 times for irrespective of the type of surgery if patients end up getting a complication. Overall, we know that 15% of our patients get one or the other complication. If you think about 10 million surgeries being conducted in the UK annually, you can see the impact that reducing this complication will have in terms of healthcare delivery, patient outcomes, and saving resources. And that's quite important, all these things taken together. So reducing complications in comorbid patients is the priority for our specialty going forward. And what is required, therefore, is an integrated perioperative approach. It will require personalized programs for individual patients, looking at how we can integrate different services. And these could be the services requiring prehabilitation, correcting anemias, correcting diabetes, correcting comorbidities, or optimizing patient for the treatment, and then enhanced recovery programs, which will then improve outcomes. We may have to change, and we are in process of changing our curriculum and our training and our practice to accommodate a perioperative approach rather than just intraoperative care for the patient. So this is how I started my career a long time ago now, where there was one anesthetist, one patient, and a very minimal monitoring. And your interaction with patients started maybe a few hours before surgery, where you made reasonable assessment, and then you took the patient through the operation, and as soon as patient was awake and transferred to the ward, your responsibilities finished. And that continues for large number of anesthetists even today. And what we find is that we become like one-man band where we're having to do lots of things because the comorbidities have gone up. So you're having to look after patients preoperatively, all by yourself, intraoperatively, postoperatively, and it has become a tedious job. And we are managing so far. But where I would like our specialty to go forward is that we take lead in perioperative agenda, and this is how we conduct our business. Like you have your team, and that team has physiotherapists, the prehabilitators, the pharmacists, the nurses, and the whole raft of people who are going to optimize patients before operation and make enhanced recovery possible after operation. Reduce the complication rate, because we know that these measures reduce the complications at least by 50%. So think about 10 to 20% people getting complications post-operatively, 10 million surgeries only in the UK, worldwide, you can imagine how many. And then you reduce the complication rate by 50%. How much difference and impact is that going to have on the way the care is delivered, but also on patient outcome, very importantly? So there is an opportunity for us as Anaesthesiologists to join forces, of course, with the surgeons, with the GPs, the nurses, and other allied workers, and start making the changes, slow changes, but smart changes, which will then enhance patient outcomes. That is where you will get the support of public and the media and the politicians. That is how I see where our future lies. Thank you.
Thank you, Dr. Mahajan. That was a very comprehensive review in a brief period of time. And I think from what you said, we can use the information to modify the educational curriculum for our trainees in the future. And maybe we can discuss that during the Q&A session. I now welcome the next speaker, Professor Marzida Mansoor, who is the professor at the Department of Anesthesiology, Faculty of Medicine at University of Malaya in Kuala Lumpur, Malaysia. She obtained her master's in anesthesiology from the University of Malaya in 1996 and did a fellowship in pain management at the Royal North Shore Hospital in Sydney, Australia. She is the president of the Malaysian Society of Anesthesiologists and council member of the College of Anesthesiologists, Academy of Medicine in Malaysia, and has been the convener for the Special Interest Group in Pain Management, College of Anesthesiologists, and is an ex-co-member of the Malaysian Association for the Study of Pain. Welcome, Professor Mansoor. We look forward to your talk.
Thank you very much, Dr. Bellini, and good evening, ladies and gentlemen. It is a great honor for me to be part of this event, and I would like to thank the Indian College of Anesthesiologists for the opportunity to share the current status of the anesthesiology specialty in Malaysia. And for your information, the specialty of anesthesiology in Malaysia is known as anesthesiology and critical care. In Malaysia, we have both Malaysian Society of Anesthesiologists and the College of Anesthesiologists that are set up to promote the art and science of anesthesiology. We are a national body that coordinates the activities of anesthesiologists practicing in Malaysia. We are also a part of Congregation of ASEAN Society of Anesthesiologists and a chapter of WFSA. And we have about 1,005 members. The College of Anesthesiologists, Academy of Medicine, was inaugurated in 1995 And the college is like the academic arm of anesthesiologists in the country and is committed to upholding the highest ethical standards and professional competence of its members. The first anesthetic in Malaya was given in 1847 in Malacca by Dr. Rattan, and currently we have about 1,200 anesthesiologists registered with National Specialist Registry. The anesthesia in Malaysia are provided strictly by doctors, i.e. anesthesiologists or trainee anesthesiologists. Previously, we have medical assistants that provide anesthesia in the remote area in Sabah and Sarawak, but that has progressively been replaced by qualified anesthesiologists. In 2010, we have only 681 anesthesiologists, but now we have about 1,200 specialists. But the country has population of 32 million, and the target is to have one anesthesiologist to every 9,000 people. Therefore, we need to have about 3,500 qualified anesthesiologists. The postgraduate training in Malaysia is provided by the universities via the master's program in anesthesiology or MEd anesthesiology since 1984. It is a 4-year training program, and we realize that there's a limited numbers of training spots that can be offered by the universities. So to improve the ratio of anesthesiologists to population, we need to have an alternative postgraduate training, either locally or abroad. So a long-term solution for was planned with a parallel pathway, a postgraduate program that was developed together with the College of Anesthesiologists of Ireland. This allowed for more training opportunities for young doctors to specialize in our field. There's also plan for a private university to start training program in anesthesiology. So every year, the country is producing around 100 to 150 new specialists. And we projected by 2030, we will have about 2,700 anesthesiologists. In terms of salary, there is still a great disparity between the income of the public anesthesiologists compared to the private anesthesiologists. And the private anesthesiologists earn 3 to 4 times more. The anesthesiologist's average base salary in Malaysia is about 400,000 per year, or USD of 90,000. The anesthetic fee in Malaysia used to be tied to surgeon's fee, so about 35% of surgeon's fee. But with the fee schedule that's called Schedule 13, that stipulates maximum fee chargeable for any procedures or consultation, there is a separate fee schedule for anesthetists. So the anesthetist fee is not a percentage of the surgeon's fee anymore. So now the fee committee in MSA is in discussion with Ministry of Health Malaysia to amend the 13th schedule and to provide coding for newer procedures in anesthesiology, especially procedures done under the done outside the operating room. In terms of safety and quality assurance in anesthesia, both the society and the college have come up with many recommendations. One of it is recommendations on minimum standards of monitoring during anesthesia, which include mandatory use of pulse oximetry and canography. Advanced monitors such as BIS, cerebral oximeter, and hemodynamic monitoring such as flow track sensors, ultrasound, and TE are increasingly used and also available. Latest drugs such as remifentanil, dexmedetomidine, and sugammadex, and smart pumps for target control infusion are also available. TIVA is increasingly used in Malaysia apart from the conventional inhalational methods. These are some of the guidelines and recommendations that the college and society has produced. We also include management protocols in intensive care. And these are some of the society's activities, which include CPD. Last year alone, we had 34 CPDs and webinars. And we religiously celebrate National Anesthesia Day. And last year was the first time we had it virtually. We also subscribe journals online for members in benefit. During the COVID-19 pandemic, we have come up with donations of equipment to a hospital in Sabah. And we are extremely proud of some of our members who, without any hesitance, volunteered to assist the Ministry of Health hospitals as and when the need arises. We also has increasingly play a role as an advocate, as we come up with press statements and guidelines related to COVID-19. And these are some of the press statements that you can see here. We also have to do some debunking the myth work with coming out with press statements. Via our scientific and educational trust funds, we also provide financial support for attendance at conference overseas and provide grants for research for our members. And last but not least, we also organize the annual scientific congress, and the next one will be in August from 6 to 8, August 2021. And we also have allocations for free registration for societies in India, Sri Lanka, Southeast Asia, and Korea. Till then, stay safe and stay healthy, and see you at the Congress. Thank you.
Thank you, Professor Mansoor. And I think the information we provided was quite new to many of us. So we will continue the conversation as we go on. Next speaker is Professor Tipu Sultan from the Pakistan Society of Anesthesiology. Professor Tipu Sultan is a patron of the Pakistan Society, and he has many laurels. He has served as the head of anesthesia as well as medical superintendent at Karachi Civil Hospital, has been the principal of Dow Medical College and dean of the faculty of anesthesiology at the College of Physicians and Surgeons. Welcome, Professor Tipu Sultan, for joining our session, and we look forward to your talk.
Hello, I am Dr. Tipu Sultan from Pakistan. I belong to Pakistan Society of Anaesthesia. I would like to congratulate the organizers for organizing this seminar. I would like to, as asked, I would like to give a talk on anesthesia, current anesthesia practice and future trends. I came back to Pakistan 45 years before, in 1976, and the anesthesia practice in Pakistan was regional anesthesia. The general anesthesia was by ether and trichloroethylene, and then halothane came, and then other agents came. Well, in the last 45 years, the practice of anesthesia has increased tremendously in Pakistan. We in Pakistan have now scientific and developed smart anesthesia at this moment. I would like to divide anesthesia practice in Pakistan into urban and rural practices. In big cities, we have got very nice hospitals where we are practicing the most modern anesthesia. And of course, in the rural areas, far-flung areas, the general anesthesia is there, but not as advanced or monitored as one should wish. All hospitals are very busy in our setup, maybe public sector hospital or private sector hospital, or in a city or big city or a small city. Urban hospitals and tertiary care centers, they have got all the facilities of state-of-art anesthesia, which it is given for any state-of-art surgery. Rural small centers are busy places and have mostly regional anesthesia like spinal anesthesia. When we come back to the urban centers in cities which have got a modern public and private hospitals, having a state-of-art anesthesia for all state-of-art surgery like organ transplantations, example liver or kidney, which is as a routine practice. And obviously robotic surgery is being done in the tertiary care hospitals in Karachi and Lahore and Islamabad. In the last 45 years, advancement in anesthesia has helped tremendously for advancement in all surgeries in Pakistan. We are not short of skilled surgeons. All sort of surgery and anesthesia is available in public sector or private sector hospitals. In all hospitals, pre-anesthetic care is mandatory, which is a good news, and it was not available about 30-40 years before. For general anesthesia, all the medicines molecules are available as in anywhere in the world. Anesthesia equipments are also available as in any advanced setup in the Western world, which we keep on visiting. 4 centers are providing routine liver transplant facilities in Pakistan, and the management of anesthesia is done by anesthetists who are also intensivists too in that setup. Use of ultrasound is very common in tertiary care hospitals for regional blocks and venous accessibility. Targeted anesthesia for these equipment is common in city hospitals. Big public sector hospitals are managing 34 plus ORs in the cities like Karachi, Lahore, Islamabad, and managed by the anesthetist team who are busy about 8 to 10 hours providing safe and smart anesthesia. Critical care unit is mostly managed by anesthetists. Only few pulmonologists are available who are managing critical care. Postgraduate training leading to 2-year minor diploma and 4-year major diploma is very popular. For rural Pakistan and peripheral cities, we are short of trained anesthetists. Most of surgeries are performed under regional anesthesia like spinal anesthesia. In the far-flung areas, even trained technicians are providing services which are in the very, very peripheral hospitals because there are no anesthetists available. Almost all anesthetic agents except propofol is manufactured in Pakistan. Anesthetic equipments and ventilators are all imported, which are made by multinational companies of standard quality. This pandemic coronavirus has tested healthcare system of Pakistan very, very severely. We were appropriate in operation rooms and critical care management, not short of beds or facilities, which was a very fortunate part of it. The future trends in Pakistan seems to be that our younger students and younger colleagues, younger fellows, they are heavily tilted towards safe, balanced and smart anesthesia using new molecules and new gadgets. Ultrasound guided regional blocks and venous access is getting popular to our younger doctors. Safer use of old molecules like ketamine is getting popular. Dexmedetomidine and citalopram is popular nowadays in our big hospitals. Structured training program is popular and mandatory for our young anesthetists. But after this training program, we lose our trained anesthetists in large numbers to Middle East countries and Europe, which is a very sad story, which we can call it brain drain as such. Well, in a nutshell, in our big hospitals, all the surgeries are being done, and I am witness to all these activities in the last 45 years when I landed back to Pakistan after staying 7 years and working at Charing Cross. Obviously, I can remember that ether anesthesia and trichlorine anesthesia was there. Halothane came right in front of me in 1977 in Karachi. Obviously, we have got rid of all those molecules and all those drugs, and latest model anesthesia machines and drugs and medicines are available. I can say very confidently that anesthesia practice is as advanced as in India. I have seen in Bombay and Delhi and in Dhaka too. In Karachi and other cities of Pakistan, we are doing quite well with the management of every sort of surgery, because we are very fortunate to have excellent surgeons, very well trained surgeons, and they demand a very powerful anesthesia which we are providing. Thank you very much for your listening. Thanks.
Thank you, Dr. Tipu Sultan. Glad to hear that the anesthesia that is being provided is of high quality in the country of Pakistan, and that the SAARC countries are doing well in anesthesiology. Our next speaker is Dr. Tamasi Makulu Loa, and she is a professor and consultant anesthetist at the Faculty of Medicine, General Sir John Kotiliwala Defence University in Sri Lanka. She is the president of the College of Anesthesiologists and Intensivists of Sri Lanka and has been so during 2021 and 2022. She has a special interest in the field of pain medicine and has several publications to her credit. Welcome, Professor Tamasi, and we look forward to your presentation.
Good evening. On behalf of College of Anesthesiologists and Intensivists of Sri Lanka, I would like to thank the organizers of the Indian College of Anesthesiology Academics Annual Day 2021 for giving us the opportunity to brief on current status of anesthesiology in Sri Lanka and what does the future look like. In my short presentation, I will be focusing on the anesthetic services at present and prospects for the future. The total population of Sri Lanka is approximately 21.5 million. The Ministry of Health is the main healthcare provider of the country, where services are available totally free of charge. Health expenses of Sri Lanka as a percentage of government expenses is about 5.94%, and as percentage of GDP is about 1.54% as per the statistics of 2017. The private sector in Sri Lanka too provides a significant contribution on a payment basis. The private healthcare services are regulated and are under the direct scrutiny of the Ministry of Health. Sri Lanka is divided into 9 administrative provinces. Tertiary and secondary care hospitals are established based on the population in the provinces. Depending on the facilities, state hospitals are categorized as national, teaching, specialized, provincial, district, and base hospitals. Total bed strength in both the state and private sector is about 63,000. State sector hospitals provide fully fledged anesthetic services along with critical care services on a 24/7 basis. Current availability of critical care beds is about 550 at a ratio of critical care bed per 100 hospital beds. However, numbers have increased during the pandemic by another 100 to 150 beds. The majority of beds cater for both surgical and medical patients requiring intensive care. A few main centers run regular preoperative assessment clinics. Acute pain services are provided by the anesthetic team. However, only a few main centers have established fully fledged chronic pain services with referral system available across the country to cater on a countrywide basis. In terms of human resources, we have about 225 consultant anesthetists currently working in state and private sector hospitals. About 210 postgraduate trainees are in their different stages of training. Along with PG trainees, another 660 medical officers provide anesthetic and critical care services throughout the country. Additionally, consultant intensivists specialized in critical care and their PG trainees mainly take care of patients admitted to specialized ICUs such as medical, neurological, coronary care units, etc. The College of Anesthesiologists and Intensivists of Sri Lanka. The college serves as a professional body representing anesthesiologists and intensivists of Sri Lanka. The college was inaugurated in 1957 as Ceylon Society of Anesthetists and subsequently in 2014 established as College of Anesthesiologists of Sri Lanka. The two faculties were formed under the same banner to represent the specialties critical care and pain medicine. The 50th annual general meeting of the college was held in January 2021. As per the constitution of the college, the goals of establishing the college are to maintain high standards of clinical practice, advance knowledge, promote research, and to advise on training and education in anesthesiology, critical care, and pain medicine. The college intends to achieve the stated goals through capacity building and implementing appropriate changes to the care delivery system, regular reviews and reviews for talk programs, sharing experience and expertise with the Board of Study in Anesthesiology. Finally, the college is also committed to strengthen links with its membership with a view to upholding welfare of its members. This slide shows the administrative structure of the college, where a governing council of members headed by the president entrusted with the administrative powers of the college. Governing council appoints members to the faculties and committees of the college established under the same banner. Active membership of the college at present is about 430, with a total of over 500 members, including overseas and retired members. As a professional body, and in keeping with the goals, college primarily focuses on its academic CPD activities and PG training programs. Additionally, funded scholarships are made available for researchers. The college publishes its journal, Sri Lankan Journal of Anesthesiology, biannually, providing a platform for local researchers to publish their work. The college conducts postgraduate training programs targeting the courses conducted by the PGIM on a regular basis and provides guidance and additional supports for the prospective trainees to facilitate acquiring their learn outcomes. Scientific sessions, the main academic event of the college, is conducted annually with the participation of both local and overseas renowned speakers to update knowledge and skills of the workforce. Faculties, critical care and pain medicine also conducts the annual sessions and regular courses and workshops with a view to enhancing clinical services and to achieve improved outcomes. The Faculty of Critical Care Medicine played a key role in developing COVID-19 local guidelines and arranging and conducting webinars and short training programs for the medical and nursing officers. The Working Committee on Resuscitation is another branch of the college. The ERC instructors of the Working Committee on Resuscitation oversee the conduct of European Resuscitation Council approved courses such as ERC ALS and ILS, apart from ERC GIC in liaison with the ERC. Additionally, other courses such as ALS Local, ILS Obstetrics, BLS Kids Save Lives are also conducted regularly. During the COVID-19 pandemic, the college played a main role in expanding critical care services in liaison with the Ministry of Health in meeting the demand for COVID patients. The members of the college were directly involved in expanding the ICU facilities, training of workforce, developing local guidelines and protocols, and providing necessary advice and guidance to policymakers. The PG training in anesthesia, intensive care, and pain medicine is conducted by the Postgraduate Institute of Medicine of Sri Lanka, established under the University Grants Commission. It's a state-run institute which oversees the PG training in MD anesthesiology programs, apart from accreditation of courses and conducting exams to evaluate training in liaison with the Royal College of Anaesthetists in the UK. The PGIM also conducts training of trainer programs, curricular reviews, etc., ensuring quality of its LD programs. In the future, as anesthesiologists responsible for perioperative care, we hope to establish perioperative care services with a view to improving perioperative outcomes. Additionally, plans are underway to expand critical care facilities by expanding infrastructure facilities and trained human resources. We also intend to streamline the existing acute pain services by increasing the number of available trained and skilled staff and to establish chronic pain services covering the majority of main hospitals in each and every province under the direct supervision of anesthetists trained in pain medicine. In summary, the College of Anesthesiologists and Intensivists of Sri Lanka plays a vital role in maintaining and raising standards of education and training of workforce and quality and safety of clinical services in anesthesiology, intensive care, and pain medicine in Sri Lanka. Thank you.
Thank you, Dr. Maklukova. That was great. I can see that you all are well situated with your training programs, and we will discuss a bit during the Q&A about this. We move on now to our next speaker, and this is Professor Debabrata Banik from Bangladesh. He's professor in the Department of Anesthesia, Analgesia, and Intensive Care Medicine, and the Dean of Medical Technologists at Bangabandhu Sheikh Mujib Medical University. He is also the president of the Bangladesh Society of Anesthesiologists, and he's interested in neuroanesthesia and critical care and also pediatric anesthesia. And he is a member of the World Federation Society of Anesthesia Pediatric Committee. Thank you, Dr. Banik, and we look forward to your presentation.
Thank you, and good evening, and everyone, and thanks to the panel, chief coordinator of the panelist, Kumar Belani, and I am getting from Bangladesh Society of Anesthesiologists and Critical Care and Pain Medicine for arrange excellent, essential, time-demanding online panel discussion on the occasion of academic annual day program of Indian College of Anesthesiologists. This in Bangladesh is a dense populated populated country with a limited health facility, which is shown in our health facility here, and this is our whole health facility of my countries, but universal healthcare within 2030 and achievement of the SDG, surgical and anesthesia and obstetrician manpower is 20 per 1 lakh, and minimum anesthetic qualified manpower is 4 in per 1 lakh. But in our setup, especially surgical manpower is including all, is 0.5 to 5 per 1 lakh, and anesthesiology is 1.4 per 1 lakh. In health facilities, despite of all above limitation, Bangladesh has built over the first decade a good network of primary, secondary, and tertiary care hospital and health center to provide primary and referral health care to its citizens. And present perspective is that the increased demand of the surgery and operation theater increase. The government primary level operation theater is 425. Secondary and tertiary level operation theater is 590. Primary level private OT is 1850, and secondary and tertiary operation theater is 278. All type of surgery in secondary and tertiary hospital is occurred. Number of anesthesia per day about 1800 per day. 50% are provided by general anesthesia. Safe anesthesia service, it is essential for the safe surgery and patient safety for the medical legal importance. Increase awareness of the pupils and patient. The aims of our anesthesia provide. So anesthesia is provided by trained, skilled anesthesiologists from the urban to rural area by using modern device and monitoring equipment, good anesthesia machine, pulse oximeter, safe drugs, and backup support. Present activities of the anesthesiology in Bangladesh, provide perioperative care, provide anesthesia during the operation, provide post-operative care, especially provide the and management of critical cares, the duties in emergency care and emergency resuscitation procedure, and expansion of the anesthesia service. Besides the providing perioperative and anesthesia care, anesthesiologists are also involved in intensive care. Most of the ICU in Bangladesh is run by the anesthesiologist in government hospital, and pain management and some palliative care. Bangladesh over anesthesia coverage, remote area is not covered by any none. Rural area hospital, poor coverage. Urban area, teaching hospital, physically present 24 hours in emergency and routine operation. And 50 to 100 bed hospital in district level, all available on call, anesthetist, and small hospital, there is a poor coverage of the anesthesiologist. COVID-19 pandemic situations, anesthesiologist is more vulnerable to great infection, both in operation theater and ICU, more and more exhausted with his workload, and start activity without knowing more with this limited manpower. BSA collaboration with the Health Ministry provide national guideline for operation theater management and ICU management of COVID-19 patient. Now all are mentally depressed, need support both physically and psychologically and economically. Manpower development plan, BSA with government try to increase skilled anesthetic manpower, providing following suggestion to increase the training post, to encourage the junior doctors, training at home and abroad, to create more posts for postgraduate anesthesiologists, change in postgraduate and undergraduate curriculum, national need-based postgraduate medical education. Postgraduate medical education, aim of the training and education in anesthesia to provide the high quality anesthetists with a broad range of skill that will enable them to practice as a specialist and consultant anesthetist. Anesthesia practice is the sharp-edged specialty. Academic qualification of the all anesthetists in Bangladesh is provided by the College of Physicians and Surgeons, FCPS. This is the 5 years course, and MCPS is the 2 years course. Bangabandhu Sheikh Mujib Medical University provide the DA, Diploma in Anesthesiology in 2 years course, and MD residency in 5 years course. Foreign universities, FRCA, American Board of Anesthesiologists, and PhD diploma is also in the outside anesthesiologist qualified from the outside of the country. Entry criteria of the postgraduate education in Bangladesh: direct entry, MD residency, and FCPS Part 1. No required prerequisite training, diploma in anesthesiology, and FCPS Part 1. Prerequisite training is only required in MCPS 1 year and FCPS Part 2 5 years. Principle of training, teaching and trainings in Bangladesh is all training are structured, and principle of training in anesthesia is constructed so that all anesthetists have the same core skilling, and training should undertake full-time trainers. Principle of training and teaching: the course curriculum is the competency-based, evaluated, and has clear objective, and by appropriately appointed trainers, and allow time for study and accommodative, and it is planned and supervised. And also the certain generic professional skill as essential to the training should be covered: attitude and behavior, communication and presentation, audit, teaching, ethics and law, and management of the all communicable diseases. And place of training, teaching and training: recognized medical college hospital and medical university hospital. Single specialty hospital, a unit of specialized training only is recognized, is not given any form of degree. And district level hospital, short-term training recognized. A teaching method is our didactic lectures, workplace-based training, learning, supervised clinical supervision, educational supervision, formal education, and research. In spite of the shortage of our anesthesiologists in Bangladesh, more of the brilliant anesthesiologists leave the country, and especially, and most of Bangladesh qualified and specialized anesthetists are now working and serving in other countries: England, Ireland, Middle East, and Malaysia. Commitment: many do not like to commit to a practice when one has to be responsible, and many option for locum or emergency work, so there is a flexibility and no commitment. Anesthesia care reform demand high commitment. Anesthetic FL, despite there never have been any meaningful investment in anesthesia research, anesthetic always work and are incredibly safe. Anesthesia, providing safe anesthesia, its mortality rate is less than 1 in 10 lakh population. In cardiology, despite having an investment million of medical research council found in cardiology and heart disease remain in the commonest killer in the UK, and little or no progress has been made despite having the most professional and the biggest department. But still, this is also in our same things in our country. Challenging in anesthesia in our country: adequate manpower development far behind for our expectation, but we try to maintain the quality. We cannot provide attractive future of our juniors, no equalization of the fee during the private practice, not provide social security due to the lack of awareness. We estimated that in order to achieve a reasonable standard of healthcare indicated by the global median maternal mortality rate, and country should aim to have at least 4 physician anesthesiologists per 1 lakh population. Existing data show that currently country have more behind than this number. Thank you.
Thank you, Dr. Banik. I can understand all the problems you guys had to undergo during COVID and the manpower situation that you experienced. Our next speaker is Professor Radhakrishnan, president of the Indian College of Anesthesiologists, is a senior anesthesiologist and a faculty of anesthesia and emergency medicine at GG Hospital in Trivandrum, India. Before becoming the national president of the Indian Society of Anesthesiologists, he was a national secretary in that society, and he is currently the president of the Indian College of Anesthesiologists. He has also been the president of the Indian Society for Study of Pain. Welcome, Dr. Radhakrishnan. We look forward to your comments, and thank you for hosting this annual academic day for ICA.
Dear colleagues and friends, good evening to all. Indian College of Anesthesiologists welcome you all and thank you all for supporting our academic activities. This academic college is an autonomous education trust formed in 2008 with the support of our parent Anaesthesia Society of India and now exists as a freestanding academic institution spread over India and outside. The mission of creation of this outlet was to bring in uniformity in anesthesia education in India, equity in anesthesia delivery all over India, and to promote allied specialties of anesthesia. The growth of anesthesiology in India happens in the last 75 years. India is a developing country and developing in all areas, but still has setbacks of an emerging economy and of multiracial, multicultural civilizations. Today we have around 65 million patients reporting every year with varying illness at Indian hospitals in normal times and requires anesthetic services to around 40 million people annually. We do have around 500 collegiate medical institutions providing medical education. Anesthesia education in the country, apart from limited exposure during the undergraduate days, is offered as 3 years residential training program leading to independent postgraduate medical qualification permitting to practice anesthesiology. On an average, 1,300 students attend each year for postgraduate degree programs through 350 odd collegiate institutions, as well as private hospital institutions. Within 3 years of training, a basic medical graduate is brought up to the individual capability to practice anesthesia independently, and we label him as physician anesthesiologist. If any of the anesthesia postgraduate degree holder or say the physician anesthesiologist like to join academic career, they are directed to do another 3 years of clinical practice in anesthesia under supervision at a collegiate hospital, thus totaling to 6 years of exposure in the subject before turns out as an anesthesia faculty or trainer. The medical courses in India are regulated by 2 different national bodies, namely National Medical Commission, replacing the earlier existing Medical Council of India, looking after the medical education in India, and another institution titled National Board of Examinations, conducting postgraduate examinations. The courses, as said earlier, are conducted at collegiate hospitals by the medical universities in their geographical area controlled by the National Medical Council, and at major private hospitals controlled by the National Board of Examinations. The number of seats in each institution under both streams decided based on the faculty, facilities available for teaching and training, and patient load available. The selection of admission to the course is based on merit of national community examination conducted amongst medical graduates. Earlier, we had a 2-year-long course leading to diploma in anesthesia, which is being phased out. Apart from this, subspecialty anesthesia education goes on at different institutions controlled by the institution as well as board of examinations. The number of anesthesiologists qualified in India as on date totals to 90,000, of which nearly 15,000 are working outside India. Anesthesiologists in India works in clinical anesthesia, critical care medicine, pain medicine, trauma, and disaster medicine. We are achieving gender equality in number of anesthesia practice, and the trend shows female anesthesiologists will markedly lead over male anesthesiologists in numbers in a decade. We do have over 2 dozens of anesthesia societies or organizations in the specialty in India. Short-term career courses or say nurse anesthesia career concepts are not promoted in India. The major anesthesia society of the country is Indian Society of Anesthesiologists, and they are engaged in welfare, social, and cultural activities of members apart from academic areas. Indian College of Anesthesiologists concerned mostly in promotion of academic activities as per our mission statement and are achieving our target through systematic modular teaching and training, literature supplements, protocol publications on various aspects of practice. We made rapid strides in academic promotion through continued vigilance, correctional education, and mentoring. As our practice style is concerned, earlier all over India, British style of anesthesia practice was followed, which is now replaced with international understandings on ways of practice. But we may have to improve ourselves in procuring and stabilizing in the use of various gadgets as well as documentation in everyday practice as in developed countries. Even with all these deficiencies existing currently, the mortality and morbidity rates in India are only marginally above the figures of developed countries. Secondly, we admit morbidity and mortality associated with obstetrics is higher in rural areas of India, and we are bringing up measures in our reach to reduce the same. Most of the surgical procedures carried out all over the world today are practiced in India too, within a short interval of introduction elsewhere, with needed local adaptation and available support. Safety standards as per World Health Organization, insurance groups, and local regulating authorities need further reinforcement in India. As for future of anesthesiology is concerned, in India, anesthesiology education, career and practice sounds better at least for next 2 decades. We may take over a decade to achieve minimally required manpower of anesthesiologists and support staff in India as per World Health Organization standards. More number of institutions are being selected for teaching and training. And with us, academic career is accepted superior to non-academic practice. Anesthesiology is the second largest based hospital specialty in India. Demands for post-graduation education in anesthesiology in India is increasing. Anesthesiology, even with its inherent handicaps, occasional long hours of work, stressful career, less social mingling, unattractive pay compared to others, is preferred by Indian doctors in India. Doctors opt anesthesiology even though the salary is low because the regular workaways at most places, flexible shifts, limited patient relation, easier to relocate, as well as the absence of less number of medical legal suits in anesthesia. At present, our specialty is a leading vocation in India in the healthcare. Unfortunately, since no career counseling prior to admission available or mid-course stage of specialty is not possible in India, the future of interest with our young physicians will vary in future. Research in anesthesiology in India is at low key. Fundamental research is poor, whereas application research is going on very well. This is common to pharmaceuticals, equipment, and software makers in anesthesia. Medical disciplinary regulations in India is embedded in the Consumer Protection Act of India, and India has to come out of the consumer laws with a definite medical practice law for further redefining of our practice and reduce the burnout. Data security and projection based on data available has to be stressed in India. Protocol implementation through court of law has to be brought in. The global future in anesthesiology, as we look at, depends on technological advancements, group consolidation in practice, increase awareness of anesthesia amongst the public, and facilities to engage in allied areas. Indian College of Anesthesiologists, thank you all for listening us and wishing you all bright career ahead. Thank you.
Thank you very much, Professor Radhakrishnan. We have now concluded the presentations by the world leaders in anesthesiology. Several of them are going to be on the panel right now. A few had to be excused because either it's too late in the night or some are catching a flight and things like that. But I will start off by thanking all the world leaders for giving us their presentations, guidance. And one of the things that came out is that the horizon for anesthesia is pretty good. It looks like we are needed in many countries. It looks like there's a manpower shortage and looks like there's an opportunity, especially for advancement, not only in ambulatory anesthesia, but also in research. It looks like the education is going on well, but we could learn from each other and share certain curriculums. I will start off with Bobby. Are you on the panel right now?
Hello. Yes.
Good, Bobby. Thank you.
Hi there.
Thank you for participating. And looks like we are doing a fair number of ambulatory cases in the United States. The numbers are increasing every year. The patients that are getting done on an ambulatory basis are sicker and sicker, but we are accepting some of them. What do you think about developing a curriculum, especially with the countries that we have participated with, so that we have a nice uniform curriculum? And how could SAMBA help so that we can actually implement some sort of a training program and then give them a certificate from SAMBA or something like that? Do you want to say a few words about that?
Sure. I think that we all know that, it on average, apparently it takes about 17 years for a proven therapy or best practice to actually get disseminated out to everyday use among practitioners. So I think we know that there's a lack of transference of education and information and best practices and all, sharing of the best way to take care of patients. And I think, a society such as yours and ours, SAMBA, really should band together to try to facilitate this transfer of knowledge and to help people, be familiar with practices and best evidence. And we know that, sometimes some things that we do in the United States is not directly transferable. But, I think that we can share and work together and educate each other and help us learn how and develop ways to better take care of our patients. I think a lot of this, occurred even, with this pandemic in the last year, right? A lot of that early information that was coming out of Wuhan, China, and their identification of the virus and the genome really helped facilitate testing, helped facilitate the development of some of the vaccines. We know that India, has always been a, wonderful producer of vaccines. And, yet it's, I think there were some challenges of, early on getting those vaccines to your own population. And, we in the United States have been very lucky to be economically a rich country and to have resources. But, we didn't do so well with the pandemic either, right? We know that we're all very vulnerable when, things to certain forces of nature. So I think the more we can, band together, work together, develop things, disseminate things, have opportunities like this where we share in conferences is a great idea. So Dr. Belani has been a wonderful, person to outreach to a lot of our different, people who, when he was president a few years ago, to develop these relationships, and especially, in India. So I look forward to working with Dr. Belani and our board of directors and our team at SAMBA to see what we can do together.
Thank you. Anybody have any questions amongst the panelists or anybody else? Dr. Mansoor, what about the situation in Malaysia in terms of the pandemic? Did your government was able to provide support for the critical care services needed?
Yes, thank you very much, Dr. Belani. It is regrettable to say that we are not really coping at the moment, because now we have, in spite of doing very well at the beginning of the pandemic, but now our healthcare services are being overwhelmed. And in Malaysia, we have about 800,000 cases now, and we have about 6,000 deaths. And we are trying our very best to cope by ramping up the vaccination. But even then, now we only have done about 7% of the population has been vaccinated. So we are trying our best at the moment.
Thank you. So I think it's the same issue in many places, lack of vaccine and lack of resources to deliver the vaccine to people. And I hope that things will improve over there. Dr. Tamasi, what about Sri Lanka? Is the manpower situation okay there? What do you think about more and more ambulatory cases? Do you all have an ambulatory care system for anesthesia for outpatients?
Well, no, we don't have. We don't have an ambulatory care service in Sri Lanka. Hello?
Yes, we can hear you.
Yes. So it's mostly the services are provided inside the hospitals. So it's the standard care that we provide the patients.
Is that because patients prefer to be in the hospital rather than go home on the same day?
In fact, at least in the main hospitals, we really wanted to start these services. But at the moment, the things are not in place for us to start the kind of daycare services for these patients. But in private hospitals, there are certain places where they practice day surgeries for minor procedures, but it's mostly the in-service services are provided for these patients.
So I think, Dr. Belani, if I could just speak briefly. So, I think if there's an opportunity for, especially virtually now and with Zoom visits. Sometimes, we would have people we invite from other places to come and visit us here in the United States to observe some of the things we do. And, we could share and you could see, because sometimes even though you read it or we talk about it, I think to actually actualize that in practice can be a bit more challenging and seeing it. But I think that people are also setting up opportunities for Zoom meetings and Zoom visits where we can share things. And I think, it's a whole nother step to sort of jump to like these freestanding, ambulatory centers like we often have here in, the United States and other kind of Western countries. But, just simply starting in your own hospitals where, it's for certain low risk procedures where, maybe if you can identify a group of surgeons and anesthesiologists, and even having patients, maybe plan for a little bit more extended stay, but not really true inpatient, and I think maybe sending them home after the procedure is a little bit easier to manage than having them come in that same day. And you kind of take it off in little pieces. You kind of start with baby steps and a gradual introduction of this concept of, truly outpatient surgeries. So, if your groups are interested in some of the countries that don't have this, I think, that's another thing that Dr. Vellani and Samba and some of us who work in these ambulatory spaces would, be happy to work with you because there can be a lot of cost savings, for your institutions, a lot of, resource savings. And then, of course, with something like, the pandemic where, your hospital beds are often reserved, for those other, sick patients that I'm sure maybe patients are not getting surgeries that they could have or diagnostic tests that they have because you just may not be able to accommodate them in the inpatient setting.
Thank you. I think we missed Dr. Bobby to come to India last September because we didn't have the live meeting. She was all ready to come and share her views and share her knowledge and help us with all these things, but maybe sometime in the future. Dr. Banik, what about Bangladesh? How's the situation there in terms of hospital beds and providing ambulatory care? Are you on the line, Dr. Banik? We'll give him a second. You may want to unmute if you're on the line. Dr. Banik? Yes. Unmute.
No, unmute.
Yeah. Well, what do you think is the situation in Bangladesh in terms of capacity and care as an outpatient?
Bangladesh, thank you. And for giving us time to comment about the situation. Now is Bangladesh in pandemic situation is very bad.
Okay.
And there is one of release. We are now to an hospital bed. We are exhausted with working with the COVID-19 management, especially both in administration and clinical services. Anesthesiologists are very short, and because they have no time to isolation or quarantine, many of our colleagues already have died or suffering from the COVID-19, and also the suffering there.
Okay.
Many of our colleagues also have a COVID positive, and this is the actual situation in Bangladesh with the full dose of COVID. They also have a COVID positive. How it is possible? But the symptom is less, but they have a COVID positive. But symptom is less, but they have a COVID positive.
Thank you. So that's good to know.
And their family is suffering.
Okay. Okay. Well, that's. Hope the situation in Bangladesh improves. Dr. Balakrishnan, Radhakrishnan, what do you think about India now? Are we ready for moving into the ambulatory world?
Thank you, Dr. Bellani, for the question put across. And good evening once again, all the international ladies. Well,
one question to Balani is before I finish.
India and Indian healthcare really welcome the ambulatory services. We do have ambulatory services in a different way. We have the outpatient work as well as the daycare work going on. But as such, it goes on in US or in the Western developed areas. We don't have the ambulatory care services. As practiced there, owing to the shortcomings, well, we don't have that much of transport facilities in certain areas. As well as we don't have that much of good communication which exists in the developed areas in the healthcare area. Probably in another 4 or 5 years' time, we also could look forward to that. And we welcome the Samba President's idea that a course on ambulatory anesthesia could be carried out. And probably that's going to help a lot. And we look forward to that.
Thank you. As one of our senior deans, the Indian College of Anesthesiology says, ICA fellowships are open to neighboring countries if the basic qualification is equivalent to that registrable in India. So that's a good news to have for fellow country participants. And I think moving forward we can do that. I just want to conclude now because of time constraints. I think we had an excellent panel, and we look forward to working with all of you in the future. And as things progress, we will stay in touch. And thanks again, and all the best for the rest of the evening.
Wow, that was a phenomenal session with global leaders in anesthesiology coming together in one virtual platform. Thanks to all the international dignitaries. The Indian College of Anesthesiologists hosts a number of courses and fellowships. Our National Dean, Dr. Muralidhar Kanchi, is here with us for a brief outline of the ICA courses. Over to you, sir.
Dear distinguished guests, colleagues, friends, ladies and gentlemen, good morning, good afternoon, and good evening. I welcome you to the ICA annual celebrations dated 14 July 2021. This is to commemorate the first successful webinar conducted this year last year. The ICA, that is Indian College of Anesthesiologists in short, is a brainchild of Dr. Manorama Mittal. It was established in 2008 and has grown by leaps and bounds in the last few years. Thanks to the leadership of ICA, the focus of ICA has been educational and academic activities. I will be discussing the academic activities of ICA in the next 2 minutes in a very brief manner. The ICA conducts fellowship programs. These fellowship programs are of 12 months to 18 months duration. The topics covered in these fellowship programs are cardiovascular anesthesia, pediatric anesthesia, pediatric cardiac anesthesia, onco-anesthesia, fellowship in liver transplant and organ transplant anesthesia, and Indian diploma in regional anesthesia. I am happy to say that fellowship in cardiovascular anesthesia has been very popular, and we have had international students and trainees attending this program and being successfully certified by the Indian College of Anesthesiologists. The centers which are recognized and accredited by the Indian College of Anesthesiologists in India for fellowship programs include Narayana Health City, Bangalore, Rabindranath Tagore International Institute of Cardiac Sciences, Max Health Hospital, New Delhi, Tata Medical Center, Kolkata, Medanta Medicity in New Delhi, and Bhaktavatsalam Indo-American Center, Hyderabad. We have also been conducting National Cardiac Life Support programs. We have conducted about 104 training sessions in India, and over 2,600 people, healthcare professionals, have been trained and certified in provision of advanced cardiac life support. We have also devised a way to examine candidates who have finished their fellowship by conducting online fellowship examination during the COVID-19 pandemic. This pattern has been discussed in this paper, which we have published in the Bioethics Journal. And we have had collaborations internationally with the Society for Ambulatory Anesthesia, American Society of Anesthesiologists, and the Royal College of Anesthesiologists. Myself, Dr. Muralidhar, I am the National Dean for the college, whereas Dr. Kumar Belani from Minnesota University is the International Dean. These are some of the webinars which I have been conducting in the last 1 year. And I would like to thank you for giving me this opportunity to present you the academic activities of the Indian College of Anesthesia. Thank you very much.
Now, let's have Dr. Raminder Sehgal, Manager, Publications ICA, talking on the publications of Indian College of Anesthesiologists.
A very good evening to all of you. With the aim to achieve academic excellence in the field of anesthesiology, the Indian College of Anesthesiologists has several publications under its auspices. We started in 2012 with their publication for Guidelines for Safe Practice of Anesthesia, which was edited by Professor Dr. B.P. Kumra, Dr. Jayashree Sood, and myself. And this was followed by 2 sets of guidelines from Dr. S.K. Malhotra. These 3 books had guidelines for preoperative assessment, perioperative management, and conduct of procedures required for pain therapy and the intensive care procedures. Next is the ICA newsletter, which is an online publication brought out twice a year. This was started in 2014 by Dr. Mishra in Banaras Hindu University, who compiled and published it, and later on Dr. Mathur took it over. Presently, Dr. Sanish is the executive editor of the newsletter. These newsletters contain few scientific articles, but mostly news about the activities of the Indian College. These are a few clips from the latest publication in January 2021, which has few scientific articles. And lastly, I come to the Yearbook of Anesthesiology, which was conceptualized by late Dr. Umesh Chandra in 2011 and published in 2012. He thought of publishing a yearly update on active books which were not available in India. And he, along with Dr. Basu, edited the first 3 issues. Subsequently, from volume 4 till volume 10th were edited by myself, along with Dr. Anjan Trika. And this year, a new team of Dr. Mukul Chandra and Dr. Baljeet Singh have taken over, and I'm really wish them well. Now, the pattern has been to include 25 topics of cutting-edge topics from the anesthesia, critical care, and pain. And these have been taken so well by everybody. There was some apprehension, but we have been overwhelmed by the response from all quarters. The chapters have been authored by leading academicians and subject experts from India and abroad. The feedback that we received has told us that it is very popular amongst 2 distinct set of people, the exam-going PG students, as well as the practicing anesthesiologists, especially those from non-metro cities. And I'm sure the new team will take them to greater height. These books are really a new addition to the anesthesia literature in the country. That is I have on the publications.
Now it's time for a very special occasion in this virtual meeting. I welcome Editor-in-Chief to announce it.
Good evening, everyone. We are now launching the Journal of the Indian College of Anesthesiologists. This is a journal for anesthesia, critical care, and pain management, and is the official journal of the Indian College of Anesthesiologists. Thank you.
What about our PG quiz? The youngsters and academic enthusiasts must be waiting patiently for PG quiz, the finals of ICA PG quiz 2021. Over to Dr. Sanish PJ, the academic coordinator, ICA, to begin the brainstorming session. Are you ready?
A very good evening to all. Now it's time for some brainstorming session. ProQuest 2021, the online PG quiz in anesthesiology by Indian College of Anesthesiologists. Welcome to all. Today we have a panel of for the quiz ProQuest with Dr. Muralidhar Kanchi, Dean ICA, Professor Madhusudan Upadhyay, and Dr. Aravind, along with myself, Dr. Sanish, Coordinator, ICA Academics. We had a wonderful preliminary round a few days back, and we chose the 5 top teams qualifying to the final round on this auspicious occasion of ICA Academics Annual Day 2021. First, an introduction of the panelists. Dr. Muralidhar Kanchi. Sir, please, one word.
Hi, welcome to this quiz. My name is Muralidhar. I'm speaking to you from Bangalore. I'm the academic director of Narayana Hrudayalaya at Bommasandra in Bangalore, and also I happen to be the Dean of Indian College of Anesthesiologists. Thank you for joining us.
Welcome, sir. Dr. Madhusudan Upadhyay, sir.
I'm a professor of anesthesiology in Kasturba Medical College, Bangalore. And incidentally, Sanish was our student here. And proud to be associated with this program. And all the best to everyone. May the best team win.
Thank you, sir. Dr. Aravind.
Good evening, all of you. I'm Dr. Aravind Narayanan from Chennai. I've been in Muscat, was a colleague with Dr. Sanish, and proud to be back to India and helping out all our PGs blaze a trail in their academic career. All the very best to all of you.
Okay, excellent. Now you know the panelists. The 4 people will be running the show from here onwards. Now it's time for the teams. Let's listen to Team A. Can you introduce yourselves?
Dr. Anju and Dr. Kavipriya from SAGES Medical College, Mumbai.
Okay, fine. Team B.
Myself, Dr. Pratap, and
I am Dr. Sujal from PIMS.
Okay. Team C.
Sir, I am Dr. Priya and Dr. Bhuvneshwari from Government Medical College, Kozhikode.
Okay. Team D.
Dr. Sivabalan and Dr. Kahima from Madurai Medical College.
Okay. Team E.
Dr. Deepa and Dr. Kala from Kobe Medical Center Hospital, Coimbatore.
Okay, excellent. You're all relaxed, ready for the session? So the spirit of the quiz, infotainment, should continue. You all are given a voting pad, voting instructions. Okay, all the teams will be utilizing the voting pad to send us the responses, and the score will be automatically done through this online application. Fine. Can you all see the screen? Teams?
Yes, sir.
Yes, sir.
Yes, sir. But
So,
it is not clear, sir.
Okay, so the question and the options will come on to your voting pad. So you can check the voting pad, but make sure you are visible in the video of this Zoom meeting. Okay? Fine. You can, all the teams can keep your microphone in mute mode. Let's start. Okay, we have already introduced the quiz panelist. I'm proud to be in this panel. Okay, rules and regulations of this session. All teams must keep the video on throughout the quiz. Both the teammates should be visible on screen. Microphone of Zoom should be mute unless indicated from here onwards. The voting pad should be connected online. The link for voting has already been sent and we have checked for it. So each question, remember, can be attempted once only. Both the question and answers will appear on your voting pad, so you can listen to that. What we are displaying is basically for the audience. So for any controversy or difficult decision, Quizmaster's decision will be final and binding. And remember, being an online competition, Indian College of Anesthesiologists is not responsible for the internet connectivity issues from participants' end. Okay, now what we are playing for. Okay, so this is the official wordings from Indian College of Anesthesiologists for ProQuest 2021. All the participants will be given a certificate of participation from the Indian College of Anesthesiologists. All members or all teams participating the final will be given a complimentary copy of our current yearbook of anesthesiology of ICA on their mailing address. All members, teams presenting at the final competition on 2021. That means all 10 postgraduates here as teams will be given certificate of participation from Indian College of Anesthesiologists. Now, for the winners, top 2 winners, 1 and 2, both team members will be given free individual registration to attend the ICA Annual 2021, proposed to be held at New Delhi in December 3rd week. Winners number 1 and 2, both members will be given complimentary lifetime membership in ICA. Winner number 1, team number 1, both members will be given complimentary to and fro air ticket to New Delhi from their hometown to attend the ICA annual conference, courtesy Dr. Kumar Belani, Overseas Dean ICA. Winning teams, the first and second, will be given individual mementos during the annual conference along with the certificate of merit. I hope your reward is clear. These are the teams. We have team A, B, C, D, and E, 5 top teams competing for the finals. So let's start with a warm-up round. This round will be ICA round. So now look at your voting pad. The multiple choice questions will appear on the voting pad and you can give your responses. Okay. Indian College of Anesthesiologists was formed in which year? Okay, I think all the teams are giving correct answer. Being a warm-up round, nothing much to play for. This is which is the most regular publication of Indian College of Anesthesiologists? Newsletter of ICA, ICA Yearbook of Anesthesiology, Guidelines in Anesthesia Practice, Journal of Indian College of Anesthesiologists. Voting starts now. You can vote. Yes, all the 5 teams have answered. The right answer is Yearbook of Anesthesiology, which is becoming very popular. I think the last 10 issues have come. Okay. So the right answer is Yearbook of Anesthesiology. Don't worry, other 2 teams who got it wrong will not lose anything. This is a warm-up round. What are the regular fellowship courses carried out by Indian College of Anesthesiologists? Onco anesthesia, critical care and pain medicine, cardiovascular anesthesia, adult and pediatric, liver transplant anesthesia, and all of the above. Yes, nobody hesitates to give the answer, all of the above. Actually, during the program, our dean has described which all courses and fellowships ICA is running. What are the colors in the flag of Indian College of Anesthesiologists? Black and white, blue and white, blue, red, green, white. Okay, one more team, one more response. This team is hesitating. Only 4 responses. Okay, fine. So we'll, I think those who are looking at the flag, you will realize that it's blue and white. Okay, fine. So you can go to our ICA website, and that link is already given in the brochure. You can visit our site for our updates. Okay, that was the fun part of it. Now let's begin with the true business of quizzing ProQuest Anesthesia Quiz 2021. Now I request our Dean ICA, Dr. Muralidhar Kanchi, to conduct the first round, where the questions will be multiple choice questions with 5 options each. And each question, you will have the response time of 30 seconds once you get the choices. There is no extra credit in faster response. Okay, you can take 30 seconds to answer. But after 30 seconds, you will not be given any more opportunity to answer. Clear? Fine. Over to Dr. Muralidhar.
Hello, welcome to the first round. We'll begin the first round now.
Okay, teams, you are ready? Get ready with the voting pad.
3, 2, 1, go. The first question is, who am I? I was born in Kobe in Japan, 1942. In 1982, I had my first publication, a letter to the editor suggesting that alkyronim should be used instead of succinylcholine for crash induction. I have submitted patent applications for 12 new devices. For example, device to assist venipuncture, device to prevent obstruction of anesthetic trolleys by cables, device to apply specific amount of cricoid pressure, and rotating bed for the use in intensive care to prevent bed sores. And the 13th patent was the revolutionary one and was distinguished in UK by the Colgate. It's now in its 3rd generation of modification. Please identify me. Whom am I? There are 5 names given, just identify me. Time is up. The correct answer is, I am Archie Brain. And my invention was a laryngeal mask. It was this application The 13th patent application was granted in 1982. What am I? Second question is, what am I? Approved for medical use in the United States in July 2020 and in the European Union in March 2021. I was originally synthesized in the late 1990s at the Glaxo Wellcome in their USA laboratory. Presently licensed to Pyong AG and goes by the brand name Bifago, Anarem, and Ryoma. What am I? The structure is shown on the right side. Five answers are there. Choose the correct one. Please choose the right one. So time is up now. The right answer is Remimazolam. It's a ultra short acting midazolam. The third question is, what is your diagnosis? On the post-operative visit, 8 hours after surgery on the upper arm under brachial plexus block, a patient complains of diplopia and the following clinical picture is noted. The picture is shown on the right side. What should be the most probable diagnosis? Brachial plexus was given and then patient is having diplopia. There are 5 answers. Choose the correct one. The correct answer is Bernard-Horner syndrome. It is characterized by meiosis, partial ptosis, and apparent anhidrosis with enophthalmos, as was shown in the picture in the next to the question. Fourth one is identify this needle. What is this needle? Just look at the needle tip and the markings on the needle. As usual, there will be 5 answers. You have to choose the correct one. There are 4 answers. Please choose the right one. Time is up. This is an epidural needle. Sprote needle is the name of the needle. The fifth one is look at the flow volume loops and tell us what does the loop A represent. The one on the left side is normal. The one which is red colored is abnormal. And identify the abnormality. This is a flow volume loop of respiratory system. There are 5 possible answers. Choose the correct one. The time is up now. The correct one is the restrictive lung disease. The one on the left side was normal. The one on the right side represents restrictive disease. And the various combinations are shown here. The blue one, left up top, is the normal one. And the restrictive pattern is just next to that on the left, on the right side. And you have the obstructive pattern. Next to that, we have the fixed upper airway obstruction, and down bottom on the left side, we have the variable extrathoracic obstruction, and on the right side, we have the variable intrathoracic obstruction. Thank you very much for participation.
Sir, that was the beginning. Sorry. So this is the beginning scorecard. So
yes,
everything to play for even now. Okay, this is automatic scoring. Actually, some questions like we need to decode who is what. Okay, fine. So one team got 4 answers correct. So 4,000 points. 2 teams got 3,000 points each. One team 2,000 and one team 1,000 points. Okay, fine. Thank you, sir. We'll move on to the round 2. So the thing is, round 2, you need to type in your answers. You will get 30 seconds to type in, but the answers will be very short. Don't type in informal things like that. Be it formal. And if it is a value, just give the digits. So I request Dr. Madhusudan Upadhyaya to conduct the round 2.
Ready for the round 2? Yeah, it's going to be much simpler than the round 1. I hope everyone scores out of out. Okay, all the best to you. You can still make up for the lost marks. We'll start with the next question.
Shall I start? Enter.
Yeah. Identify this equipment. Just type in the name. Okay, it is Sanders manual jet ventilator. Way back in 1967, Sanders invented this and put it into use. Only disadvantage is obviously it gives you ventilation at 50 psi, which can cause bearer trauma. And then onwards, we changed. We have been using different jet ventilators. This is the first one to start with. Okay.
Sir, shall I qualify these answers? Manual jet ventilator.
Okay, fine. Transtracheal, no.
Jet ventilation.
That becomes too easy. No.
Okay, fine. So we'll settle at that point. we'll move ahead to the next question. Starting.
Name this equipment. I want a single word. Single word. Hope you people have used this, or at least have seen this. Almost time up.
Only 3 responses, sir.
Nothing is lost by attempting. There is no negative marks, you see. The correct answer is epidrum. No. Cannot justify any of this.
Nobody scores, no, sir?
Yeah.
Yeah.
They're all wrong. Yeah, it's actually it provides you with negative pressure when you enter the epidural space. You don't have to use saline or air with your conventional loss of resistance technique. Okay.
Actually, it's a modern modification of the previously thought the loss of resistance concept.
Yeah.
Commercially available option.
It's useful. Okay.
Yes.
Next. Ready for the next one?
Yes. Question number 8 or 3rd in this round.
Please name the technique that has become a part of rapid sequence intubation to prevent aspiration of gastrointestinal contents. What do you do?
The audience will be thinking these are 2 silly questions, right?
It is. It's a simple question.
Yes. 3 responses already.
Compared to the previous one.
2 more teams.
1 more. Your time is up. All 5 have responded. Select is fine. Okay, I think it can be. All can be justified. Only spelling mistakes. I think it's all right. Meanwhile, have you people heard of reverse Selic maneuver? Reverse Selic is exactly the reverse of what you do. There is no required pressure applied, but you lift up the airway to allow the Rayleigh tube to nasogastric tube to enter. That is reverse Selic. It's there in the literature again. Yeah.
Sir, how about this modified Selic maneuver?
I think we will justify that. We will give that.
Okay.
Okay.
Fine. So 1, 2, 3, 4, 5. 5 answers.
Got can.
Yes.
Got right. Good. We'll move on to the next question. Again, an easy one. Name the new agent to reverse the effects of benzyl isoquinoline and steroidal neuromuscular blocking agents. Don't tell me it is sugammadex. The newer one. Just type in your answer.
Sir, 1 team has already answered.
Wow. Good. But unfortunately, the fastest finger first does not get more marks.
Okay.
But 8 seconds. 7, 6, 5, 3, 2, 1. Only 2 teams have tried. Okay, I think we can give it to them.
I think the team who's responded Calabadion instantly.
Yeah.
They would have expected this question.
True.
So I think the both teams, the smartphone, you would have got the message, your answer is correct. Right? Sir?
Is it?
Yeah, they will get a prompt on their smartphone.
After the time is over.
After the time is over.
Okay.
After we qualify the wrong answers and all.
Okay. Ready? Ready for the next question?
Yes.
Who developed the RCRI in 1999? Just give the name and you get the marks. Revised cardiac risk index. lot of time left. This is something which you learn first when you talk about the cardiac cases.
Sir, you can see on the right lower corner how many responses have come. 3 only. 2 more teams. Come on fast.
Come on.
Time's
It's not
up.
difficult. Only 3 have attempted. Lee is fine. Lee et al. Is fine. Okay. No, 2 teams.
No, 2 teams, sir.
2 teams
Two
have
teams.
got it right. Okay, it is called Lee's revised cardiac risk index, right? Yep. We'll go on. Hoffman elimination is responsible for approximately how much of the overall elimination of cisatracurium? Just give the number. There are 2 lines. That means that 2 digits. 2 have responded. 3, 4.
Yes, all 5.
Yep. Good.
Okay.
55.
Now you have a task now.
Yeah, I think whoever has said 80, we will give it to them.
Okay.
Then the remaining, I think it's a little difficult to say. No.
Okay,
80
so
is all right.
eventually only one team gets away with the points.
Okay. Yeah, that is the closest.
Mhm.
I think in modern medicine you cannot, but still being an anesthesiologist, we will give it to the closest answer.
Yeah, it is perfect. 80 is okay.
Yeah, 80 we will give.
80 is okay.
Yep.
Question 7.
The last but one in this round. The dash is the temperature above which a gas cannot be liquefied by pressure alone. I expected all the answers by now. One of the easiest. The first one, when you learn about the physics, you learn about the gases, 3 responses. 4.
All 5. Everyone has sorted. Good.
Good.
You
The
can
answer
take
is
rest,
the
sir.
critical temperature.
You can take rest. Everybody has
Wow.
got it
That's
right.
what I said. This is one of the easiest. Everybody should know. Yep. Congratulations. All have got it right. The last question in the round. If you answer this, I'll be happy. Okay. Ready? Name the straight out difference between the change in anion gap and the change in bicarbonate lengths. Not difficult. 2 have already given the response. 14 seconds. Still have a lot of time. 4 responses. 5. Good. Okay. Whoever has got the delta in it, I think we'll give it to them.
That's delta ratio.
Ratio, no. Delta ratio, no, I didn't see that ratio part. Delta anion gap will give it. Delta ratio, we will not. Okay. That means only one got the delta gap right, is it?
Yes, yes.
Okay.
So 2 teams take away the points.
Okay, good. That's good. Nice.
So we are through with round 2. Sir.
Round 2. Okay, this is what is delta gap is.
The scorecard swings. Yes, close fight now.
Total is, okay.
Yeah, one team actually got 8 answers right so far out of 13 questions. One team got 7 right, 6, 5, and 4. And I should say the deciding round will be the 3rd round, where even for the right answer, you might end up getting 1,000 points or 500 points. So the last round will still carry some weightage, because for the top place, there is strong competition.
Okay, all the best to you guys.
Okay, the round 3 is the actual fun of this quiz, where you will get 30 seconds to respond. If you answer instantly, you will get 1000 points for a correct answer. If you wait till the 30th second, you will end up getting only 500 points. So in between, depending on your delay in response, your score will keep on coming down from 1000 to 500, provided you give the right answer. So it's up to you to decide whether to go for the answer and get the point, or consolidate, wait a few more seconds and make sure you get at least 500. So that's the strategy which is coming in to round 3. So it's over to Dr. Arvind. The questions are also going to be slightly longer. So we will introduce the scenario and then we'll start the race. Over to Dr. Arvind.
Thank you, Dr. Sanish. Actually, I'm sweating now. We are midway through the race and we are going on to the final sprint. And it's nice to see the beautifully tapered leaderboard. We are seeing all the teams are in contention. All right, let's get started. We are now crunched for time, so I'll be leading you all quickly into it. So going on to the first question in this particular round, watch out, you need to answer as soon as possible. After I read out the question number 14 of 21, we have 8 more questions to go. Remember, you need to answer fast. The first question is identify this device. Pretty easy. Have a look. Make your options. Choose your options. And use the voting pad to get across your answers. We are down to 15 seconds. We have 10 more seconds to go. And now the race heats up. But stay focused, read the choices, and get across your answers to us. Fantastic. We
Actually,
have
nothing
got
much in this question. Yeah. Nobody got it right.
No worries. Don't worry. You're still running the race. That's the right spirit. This is a fiber optic training device, also called the Oxford Fiber Optic Training Box. So we go on to the next question. The next question, question number 2 in this round, is coming up on your screens now. Remember, answer quickly to get more points, but think and answer which was the first clinically administered curare preparation called. We all know it's curare, which was the first neuromuscular blocker, but what was the name of the preparation which was used first clinically? You have your 5 choices. Please use your voting pad. Think carefully. Get across your... Oh, wow, everyone has voted. That's nice. Fantastic. We have got the right answer being intocostrin, which was the curare preparation, which was purified and was used clinically. We didn't give the patients curare to chew or didn't give them an arrow. So it's the curare preparation which we are looking for. Shall we go on to the next question? One team has got it right. Nice to see some greens. The next question, which is question number 3 in this round. Remember, you have to answer quickly in order to get more points. The sign of myocardial ischemia, which would appear first. You have your 4 choices in front of you. Go through it carefully, which is the first sign of myocardial ischemia, which is likely to appear. Please use your voting pad. Think appropriately, no distractions. Everyone has voted with 5 more seconds remaining. Okay, I don't see a bar graph, don't see a green bar graph. The correct answer was increased left ventricular end diastolic volume. Okay, question number 4. You anesthetize a patient for elective DC cardioversion for atrial fibrillation, a common scenario in the ICU. So this question would give you the choices pertaining to this particular clinical scenario in the ICU. This is question number 17. Patient for DC cardioversion. Which of the following has the least influence on the transthoracic electrical impedance? Your 5 choices are here. Fastest finger gets highest points, but think and give your answers, please. We have 15 more seconds to go. Last 3 seconds. Everyone has voted. Wow, a wide spectrum of answers. Paddle position. Paddle position has got the least influence on transthoracic electrical impedance. All right, so ICU care, anesthetics, DC cardioversion, the other parameters do help, but when it comes to the impedance, we should think that paddle position doesn't have much of an action on it. All right, shall we go on to the next question? I think we are running the last lap, so everybody must be eager to get on to the end post. Question number 5. A patient requires posterior fossa surgery for excision of brain tumor in the sitting position. So this is the photograph which shows you sitting position, anesthetic. And then the question which follows after this would appear now. Think about the scenario of sitting position, anesthetics, the risks. The best choice of non-invasive monitor for detection of an intraoperative venous air embolism is intraoperative detection of venous air embolism. The best choice. Out of the 5 choices, please get across your answers. Read carefully. 15 seconds up. And everyone's voted. Wow, we have people who can pick up air embolism. Do we? Precordial Doppler. Did anybody get it? You must have thought about it, but that's the best choice, which is available to pick up pain signal changes, and that will tell us air embolism has occurred. Quite an important monitor to use during posterior fossa surgery in the sitting position. Anybody with neuroanesthetics experience would have picked up, but it's a learning curve for all of us. This quiz is not just entertainment and it's edutainment, but it's also real education for all of us. Let's go on to the next question. We are sort of halfway through the final sprint. The question is, you review a hypotensive patient in the intensive care. The arterial line trace appears over damped. Don't get confused, it's blue in color, but here it's shown in blue, but the arterial trace is normally red. Don't worry about it. The arterial line trace appears over damped. So what are the choices? What does the question now lead you into? An overdamped waveform, some things must be running in your mind. The option choices which would come up on your screen right now. Remember, in order to improve the waveform, the next action from your side would be, which of the 5 choices would you do immediately in order to improve the waveform and not start the patient on massive doses of inotropes or vasopressors? Remember, it's an overdamped waveform. You have the 5 options. Do we have some answers? Yes, we have 3 of the teams, 4. Last 5 seconds. Things are heating up. All 5 teams have answered. Okay, that's nice. We have some budding intensivists among us who have thought appropriate that you should examine the tubing for air bubbles before taking any clinical decision. Fantastic. Let's go on to the next question. I think we are getting a little breathless or dyspneic. Don't worry, it's COVID times. But still, we need to understand that arterial trace has to be given due importance before we take clinical decisions. But I was referring to a dyspnea all of us are having now. I'm getting breathless to see the leading team and get to the end of this sprint. The next question coming up. A 52-year-old man in ICU required intubation and ventilation 3 days earlier following aspiration of gastric contents. He had bilateral infiltrates on his chest X-ray and a PaO2 FiO2 ratio of less than 200. You decide to try prone ventilation. Prone ventilation. Let's all think about prone ventilation. What are the choices which can appear with respect to prone ventilation? We have the choices on our screens now. This is a penultimate question, prone ventilation. Quickest answer. Which statement best describes ventilation in the prone position? Which statement best describes ventilation in the prone position? The 5 choices available to us. Do you use muscle relaxants? Do you think about carbon dioxide clearance, improving oxygenation, patient survival, or is contraindication in renal replacement therapy? Fastest finger, 3 teams have already gone for their choices. I guess we have last 3 seconds. Time's up. We are coming to the last question, but yes, has anybody answered? It improves patient survival. I guess COVID, we have all opened our eyes to prone ventilation and used it much more liberally, yet with a lot of caveats. We have to be careful about so many issues in prone position. It does improve alveolar recruitment, matches the VQ, and definitely improves patient survival. That's why we have been using it rampantly, yet with adequate care. So we are coming to the final question in this round. This is a pro quest. We are looking for the pros. And the quest for the best team should conclude after this. The final question of this quiz of 2021. It's been a pleasure. All of you have given it a best shot. But the question is this: which of the following methods is best able to diagnose a neuropathic pain condition? You have 30 seconds. You have the 5 choices. History examination, first choice. Nerve conduction studies, second. Electromyography, MRI, or transient needle nerve block. You have the 5 choices ahead. Fastest finger, but make it the best choice. Wrong answer would not get you any points, but delayed answer will still get you 500 points. The last 2 seconds, and everyone's voted. Oh, history and examination, the cornerstone of all our clinical practice. So it's nice to revisit and go back to our basics. Fundamentals are important for all of us. So chronic pain is primarily from history, what the patient says, and then we go into examination. Oh, it's been a pleasure running the last lap with all of you, and all the very best to you. The leaderboard, Dr. Sanish will take over now.
Okay. Okay, then you're all ready for the final results. I think I should congratulate all the team members for staying back with us so late today. So it's been, we were also running against time also to finish in time. So most of the things did go right. I know it's been a different experience for us conducting this quiz. And first time we are conducting an online quiz with a live scoring system. Yes, as I mentioned, the connectivity issues might have impacted the score, but throughout we have seen a steady leaderboard. And I think we'll go to the scorecard now. I'm sharing the scorecard. Yes, we have the final scorecard now. Yes, so through this program, what you can observe is the team's identity being coded. So whichever symbol is assigned to team, the quiz analysts were blinded. So easily we can find out who represented this vote god, because the team who represented vote god has come out first. Congratulations. I think it's Dr. Pratap and Dr. Sujil from Pondicherry Institute of Medical Sciences. Are you with us? Team B, Pondicherry Institute of Medical Sciences. You can unmute yourself. 1 second. Hello. You can mute.
Sir, can you hear us?
Yes. Yeah. So congratulations. Yeah, you have been given that icon, no? That vote God. Correct?
Yes, sir.
Okay. You can share your video also now. 1 second. Dr. Binil, if you are with us, can you promote as co-host team ABCDE again? Okay, so here's the leaderboard. Team B, Pondicherry Institute of Medical Sciences is coming first, and Team E, who got Puffy as the icon with 7,000 points, they come second. So they are the first and second winners. Congratulations. Your prizes and certificate things, as we mentioned before, will be reaching you. We look forward to meeting you third week of December. Okay, any comments from the participants or quiz panelists? Dr. Arvind, Madhusudan sir, Dr. Muralidhar Kanchi, because it's been a different experience.
Yeah, absolutely well conducted. And what was remarkable is that it was conducted very smoothly without any interruptions or transmission problems. Very well conducted, and everything was clear. What the question and answers were clear. That is, I think, the important part of this event. And thank you very well. Thank you very much for organizing it so well. Thank you.
Dr. Madhusudan Upadhyay, sir, you want to make any comments before closing?
Yeah. Congratulations to the winners. And it was a great experience because, as I said, I think Sanish has done a wonderful job of conducting this. There has been a lot of efforts behind organizing an online quiz like this with live scores. I think it's great. We are all proud of you, Sanish, and I think it's a great thing. And congratulations to the winners and the other participants too. Best of luck to you people the next time.
Thank you very much. A comment from Dr. Arvind. Dr. Arvind, your audio is not connected. Okay. Fine. Radhakrishnan sir, you want to give any comment?
Thank you, all participating teams. You have done a wonderful job. It was a real good effort on the part of the panelists who were able to set questions and put it across to you. We hope we will be presenting this sort of quiz once in every quarter with a different twist. And welcome you all to the National Annual of Indian College of Anesthesiologists, and congratulations to the winners, and again, best of luck to the losers.
Thank you very much. So thank you for staying with us till late night. It's over to Dr. Baljit Singh for the vote of thanks.
Dear friends, good evening. Greetings to you all. After a very exciting evening of academic activity befitting the occasion of the completion of 1 year of weekly webinars and the academic activities of ICA, we are about to come to a close. And before the curtains are pulled down, I have a very pleasant duty to thank all those who have made this evening memorable. The presence of world leaders of various international and national bodies of anesthesiologists on the academic platform of ICA is a huge boost for our morale. And for this, I thank Dr. Van Morris, President of World Federation of Societies of Anesthesiologists, Dr. Beverly K. Phillip, President of American Society of Anesthesiologists, Dr. Bobby Jean Switzer, President of SAMBA, Dr. Ravi Mahajan, President of Royal College of Anesthetists, for their valuable inputs on the current status of anesthesia. I thank them profusely for their time and inspiring words of wisdom. I also thank Dr. Marziza, President of Malaysian Society of Anesthesiologists, Dr. Tamasi, President of College of Anesthesiologists and Intensivists of Sri Lanka, Dr. Tipu Sultan, former President of Pakistan Society of Anesthesiologists, and Dr. Devabranta Banik, President of Bangladesh Society of Anesthesiologists, for their valuable thoughts. Dr. Kumar Bilani, the Overseas Dean of ICA, has been instrumental in getting these world leaders on the ICA platform today and moderating the discussion. Sincere gratitude to Dr. Bilani for this and his continued support to Indian College of Anesthesiologists programs. Another moment that would remain history is the launch of the
Excuse me, sir, your audio is gone.
Sorry, is that okay? Is that all right now?
Yes, yes.
Yep.
Keep going.
Go with that. Another event that would remain history is the launch of the title of the Journal of Indian College of Anesthesiologists. This was possible with the vision of ICA leadership of Dr. Norma Mittal, the patron, Dr. VP Kumra, the chief trustee, Dr. Jashri Sood, the CEO, Dr. Mulidhar Kanchi, National Dean, and Dr. Ravinder Sehgal, the in charge of publications of ICA. Many thanks to each one of them and also to Dr. Kirti Nath for accepting the editorial challenge on behalf of ICA. Well, Dr. Sanish did a commendable job of running the online webinars every single week of the whole year. Immensely grateful to you, Dr. Sanish. And in the end, a very special thanks to Miss Anaga Sanish for giving her voice for Sanika, the genie anchoring today's virtual meeting. Besides profuse thanks, our blessings to her for a bright career ahead. Would be happy to see her alongside her dad, Dr. Sanish, one day. One last, not the least, however, our heartfelt thanks to the participants who kept us motivated and going. Their participation indeed was crucial to the success of our academic programs. Before we sign out, I would like to say, long live Indian College of Anesthesiologists. And with this, ladies and gentlemen, the program comes to a close. Goodbye and Jai Hind.